Of our bi-monthly webinars that we do. This year, I'm doing it every 3 months. They are actually public health webinar. It's not the academic webinar that stresses on academic issues. This Caesarean section, when I prepared it in such a way that it becomes a practical webinar. What's happening out there during Caesarean section? Not necessarily complying with what the textbook is saying, but it's not deviant. It's practical obstetrics. That's why I called in experts, professors of obstetrics and gynecology, to come and join us so that they can have the view what is being practiced. Is it what should be practiced? Maybe we are going against the textbook or we are going against the standard norm. So with us today, we are blessed to have two professors of obstetrics and gynecology. We have Professor Salome Masime. She's a professor of obstetrics and gynecology and an expert in maternal surgery. And we also have Professor Monokwane Sam. Monokwane Sam is also a retired professor of obstetrics and gynecology. Salome Masime is a champion in maternal surgical care. She was previously working in UCT, and now she tells me that she's starting to work she's the head of medicine in University of Witwatersrand. They've taken her. You know, if you are good in life, they'll poach you. You can't work in one place. Everybody wants you to work for her. So I'll just take this opportunity to ask them just to greet. I will present everything, and thereafter they are going to give you what the perfect perspective of Caesarean section is. And whether they align with me, they don't align me, is fine. But I'll give you what's happening out there. I've seen Professor Masime. She's around here. Professor, can I ask you to unmute just to greet and mute again?
All right. Thank you so much. It's a great pleasure joining tonight. Thank you for inviting us. Caesarean section is a topic very close to my heart because it's work that I've done, and from the time I started doing my PhD, the research around Caesarean section and how to make it safer and more accessible to those who need it is work that it's what I've done for many years. So very excited to join and looking forward to the presentation and the discussion.
Thank you very much, Prof. Professor Monokwane, just to greet so that people can see that you are here and you can mute again.
Dr. Mahapa, good evening and good evening to all your listeners. Indeed,
your lighting is not good. Your background light is not good there. Just your focus, we see the forehead, we see your forehead, okay?
No, it's okay. The voice is there as long as I'm alive and kicking.
Okay.
In a short introduction is just to say, Caesarean section, a very important topic. Thank you for choosing this topic because indeed, while mothers, it's a safe procedure, we have seen also lots of deaths following Caesarean section. So let us just discuss, we'll listen and give input. I've also been a teacher in obstetrics and I've retired, but I'm enjoying teaching students and registrars. So thank you. Over to you, Dr. Mahapa.
Thank you, Prof. Monokwane. Ladies and gentlemen, what is a Caesarean section? Actually, when you say Caesarean section, what do we mean? Caesarean section is operation where there's a removal of a baby from the mother's uterus, the womb, by an incision, cutting an incision on the abdomen and the womb. After 28 weeks, that 28 weeks is very important because removal of a baby from the womb by incision before 28 weeks is not called Caesarean section. It's called hysterotomy. It's only after 28 weeks that it will be called Caesarean section. Some people call it a C-section. In the street, there people say, I delivered by C-section. which is a procedure, surgical procedure where baby is delivered after 28 weeks by surgery. Surgical procedure involving cutting an incision on the wall of the abdomen and the womb for delivery of a viable baby. What do you mean by viable baby? A viable baby in simple terms means a baby who, if you remove that baby out of the mother, she'll be able to live outside the mother. If the baby we remove after the mother and she can't live, it's called non-viable baby. That's why removal of the baby by any incision, if it's indicated, before 28 weeks is called hysterectomy. It's not a cesarean section. That baby won't be able to live outside the mother. And cesarean section is one of the oldest operations. The history is such that the first incision operation to be done on a human body is cesarean section. All these other surgical operations, appendectomies, and they come thereafter. The only operation that predates Caesar, that was done before Caesar, is trepanation. Trepanation is an operation where they cut a hole on the skull of a baby, of a human being. It dates back more than 10,000 years ago, involving drilling or cutting or scraping a hole on the human skull. It was practiced globally, all over the world, often to treat head injuries. Even now we see head injuries, some of the head injuries, they call it a bear hole. But trepanation is different. Somebody can mute there. Please, everybody mute. Because if you don't mute, I see you here. The only thing I can do is to remove you. I can't be able to mute you. Please mute. The baby's crying there.
Wow, the baby's crying.
Let me look for this person who's not muting and remove him. Trepanation, I was talking that trepanation is the only operation older than cesarean section. And it was practiced all over the world. And people believe that it helps. They used to use it to treat head injuries. Naomi, please. They used to treat head injuries and again to treat things like headaches when there's increased intracranial pressure. Other people believe that by trepanation, evil spirit can come out of the head, but that is not true. I don't think it's true. I'll show you what trepanation is.
A doctor would drill a hole in your head if you had a really bad headache 500 years ago. They would begin by shaving the area, then use a hand-operated tool to start drilling into your skull. Some of these doctors believed this would allow evil spirits to escape through the hole. In reality, the procedure had a very low success rate and probably just caused more pain.
That was trepanation. The history of cesarean section is this. It's like this. Let me look for this person who is. Let me get a grill and remove this person who is talking, because I said I muted everybody on my side, but for some reason people are able to unmute themselves. Ladies and gentlemen, please mute your microphones, all of you. We're disturbing people. I can't see who's unmuted here. So the history is that early operations were done on dead bodies. Long ago, there were no operation which was done on human beings. They were only done on dead bodies. But later, as science improved, Nickel lady, please mute. Nickel lady, mute.
Okay, sorry.
The reason why they were done on dead bodies, it was for religious reasons. Because, for instance, if a mother dies with a baby in the uterus, they thought it was not good religiously to bury that mother with a baby inside. So then they would do an operation to remove the baby and bury them separately. And sometimes it was just for methodical reason. It was just for myth that believe that you cannot bury a pregnant woman if she dies with a baby inside. They have to separate them. What prompted people to start to think that you can remove a live baby out of a human being is by accidentally, during when they slaughter a cow or any animal, they find a fetus there, which happens always when you slaughter a cow or a sheep. You didn't know that it's pregnant. You find a live fetus inside. And some of those live babies, they live. Hey. Sorry, ladies and gentlemen, I want to get a grill here and remove this person. I'm unable to see you. Please don't talk.
Dr. Mahapa, I think it's Naomi and Oppo 5.
Naomi
and Oppo 5. Naomi and Oppo 5. They are the one causing a discomfort in the meeting.
Naomi, please. Naomi, please. Don't.
Mute.
Let me go to the grill. Naomi, mute. And you're not muted. I can see you're not muted. Okay, I've removed Naomi. I've removed Apple Pro. Okay, the Caesarean section I was saying, it was because the reason why people had to do a Caesarean section is because when they will sacrifice an animal and they find a live baby inside, whether a lamb if it's a sheep or a calf if it's a cow, they found that there's that animal can live. And they decided, because people were dying, mothers were dying from childbirth, they said probably there can be an operation that can produce a live baby because of that sacrifice. Or sometimes during war situation, accidentally, a conqueror stepped the woman on the abdomen and a baby comes out and that baby lives. And then that prompted the occurrence of Caesarean section. What makes the etymology of Caesarean section? By etymology, I mean the study of the history of the words and their connotation and meaning. The Caesarean section, there are a lot of misinformation about the origin of the word Caesarean section. The first Caesarean section that was done was in the year 1500 by a pig gelter known as Nufa. And he did this on his wife, and both the mother and baby lived. And then from there there were a lot of stories about Caesar. Some people say Julius Caesar was born by Caesarean section, but Julius Caesar was born about 100 years before the birth of Christ. So Caesar was not there during that time. It's not true. So the word Caesarean section is a pleonasm. Pleonasm is the use of two words with similar meaning, sort of like tautology, but it's not necessarily a tautology. Like the word Caesar comes from the Latin word caed or cidere, which means cut. And if you look at that, in English, to cut is to section. Section means cut, which means Caesarean section by definition, it means cut. Cut in Latin, cut in English. They just mix the two words. And it's not uncommon to find pleonasm in nature. Like similar pleonasm is Sahara Desert. You know, the word Sahara, it's a Arabic word for desert. And the desert is a desert in English. And you also, when you talk again, you find that you talk, if you want somebody to repeat, you say repeat again. But he hasn't repeated yet. You use the same words to mean the same thing. That's Caesarean section. It means cut. And children who are born out of a Caesar are called Caesones. One thing that worries academics and worries everybody, all health departments, is the increasing in Caesarean section rate. The Caesarean section rate is increasing. What makes this Caesarean section? Factors that contribute to that. One of the factors that makes Caesarean section rate to go high, was the introduction of electronic fetal monitoring in labor wards, because they pick up abnormalities very early, and then people react on those abnormalities. And with increase in socioeconomic status and treatment of women, we tend to have big babies. You know, old women used to deliver even at home because they were malnourished and they were working hard even if they are pregnant. So babies were sort of small for gestational age. Nowadays, pregnant women are treated in a special way. They don't work hard, they eat well, then the babies become big. One of the ones that is here, which our experts will touch it to what it is maternal request. Mothers these days, they just request they want Caesar for various reasons that we'll discuss later. And for that thing, most gynecologists, they give in, most of them give in and to that request and do a cesarean section. You ask a mother, why did you do a Caesar? Say, I just wanted, I said, my doctor must do a Caesar on me. The other reason is advanced maternal age. With advanced maternal age, the bones, the pelvic bone doesn't expand so much easy, and such that they tend to have CPD very quickly, especially if they've got big babies. And advanced maternal age, you can't stop it because women these days, they chase career. They chase career, say, I won't give birth. They use contraception until they finish their degrees, their higher degrees, masters, up to PhD. A person can postpone childbirth until he finishes studies or is well established in her career. One other thing which is stoppable but is flourishing is teenage pregnancies. Teenage pregnancies have got immature pelvises, small pelvises, and they've got big babies. Then they don't cooperate during labor, such that they tend to end up being a lot of cesarean section. There are a lot of other socioeconomic factors that contribute to this high cesarean section rate, which include higher education. Educated women tend to deliver by Caesar than uneducated. Urban residency, even the income, the high income people, they tend to deliver, or they like to deliver. Those are the people that will request cesarean section. And these factors are often driven by the rates through better access to private healthcare, because those people that I've mentioned, educated urban residents, they usually go to private healthcare, and private healthcare is the one that where doctors tend to agree with the patient that what the patient asks for. If they ask for Caesar, they just give them cesarean section. This increased demand is due to convenience sometimes, convenience of the doctor and the patient. In some case, without no clinical indication. One of the reasons I did ask a lot of women, why do they want a Caesar? Is sexual function, genital preservation, which I'll discuss later. And I agree that if a woman tells me that I don't want to have dilated genital, I agree. The other thing is that, previously, it used to say that cesarean section will limit your reproductive career. You can only do safely 3 cesarean sections. The 4th cesarean section, the rate of uterine rupture is very high. But these days, parity is reduced. Very few people have 4 children. The average family size of a Black family is 2 to 3. Actually, it's 2. If you find them goes to 3, they were looking for another gender. Maybe they've got the same gender, now they are looking for another gender. So even now, the surgical techniques and surgical material that are used now, they are so improved such that the wound healing becomes better, even the morbidity and mortality becomes better, such that people tend to do cesarean section willy-nilly. I've mentioned it. The rate between private and public hospital is different. Private healthcare has got a very high cesarean section rate. Public hospitals do not have. And another thing that contributes to that is the practice of safe obstetrics. With the high litigation that is present now, it is safer. Any deviation from normal, do Caesar, because normal delivery can go bad at any time, and litigation, the way it is, nobody wants to be litigated. So the Convenient for both the doctor and the patient also affected in. You find that the patient says, I've got a conference when I must deliver at 37 now, so that by after 3 weeks, I should be able to attend this function. And these days, we don't use assisted delivery as such because they also have their own morbidities. There's things like forceps that are abundant in favor of cesarean section. Even some of this destructive operation like symphysiotomy. Symphysiotomy is a surgical procedure primarily used in obstructed labor that involved cutting a cartilage of the pubic symphysis to widen the pelvis and allow the child to pass. It was once an alternative for cesarean section, but now it's very rarely done, unless in an emergency situation in a remote area. Such destructive operations like symphysiotomy are abundant in favor of C-section. And introduction of epidural anesthesia has increased cesarean section because the mother with epidural, they don't push very well. You find that you've got maternal exhaustion or maternal uncorrupation because you need maternal effort to push the baby vaginally. So cesarean section will increase. There are many indications for cesarean sections. I just chose 5. These 5 are not 5 in the textbook, are 5 that I, DT Mahapa, think they are the ones that I meet more often, mostly in my practice. The commonest one are repeat cesarean section. The expert will guide us whether it's still valid. If you've got one cesarean section for non-recurring cause, ideally, it's not necessary that the next pregnancy must be a Caesar. But I find that if a woman has had a Caesar, the next one is a Caesar, irrespective whether the indication was repeatable, was he having a contracted pelvis or what? Maybe she just had a Caesar for fetal distress. It doesn't mean the next baby will have fetal distress, but it means nowadays you got this dictum of once a Caesar, always a Caesar is coming in. Abnormal fetal presentation. If the patient presents by breach, transverse lie, or cord presentation, not cesarean prolapse or brow presentation, it definitely is going to be a Caesar. Or dystocia. Dystocia means difficult labor. We find that the labor does not progress from whatever reason, whether the mother is not cooperating or it's just labor doesn't go according to the pathogram. It's a Caesar. That's why they say any deviation from normal in the labor ward, cesarean section. And the fourth one is, of course, which lead to emergency Caesar is fetal distress. The fifth one, there's one that I mentioned later, which I put it in red so that our expert can underline it and see. The women, they request, maternal request, they say they want Caesar because they want genital preservation. They don't want to be. And I'll elaborate on it when I come there. And I'm the one of the people that if a woman comes to me and say, I want cesarean section because I don't, for genital preservation, I agree as a urogynecologist. And that my specialty has influenced me such that I agree. Then looking at the pelvis and the pelvic muscles here, during vaginal birth, more often than not, there's either dilatation or a tear downwards. Whether you cut an episiotomy or not, episiotomy might be extended. And sometimes if the baby is too big, the tear can even involve the anal sphincters, such that you find at the end of, after healing, you are unable to control your feces, or you just have a dilated genital. That way, the babies don't want it, and I'll come to indications. Then these indications that I'm mentioning here, the maternal request, one of the indications which is questionable, Luna, should we really accede to the maternal request? Sometimes the mother will ask, why do you want a Caesar? She said, I see you say expected date of delivery is this month, is May. I'm also in May. I want our birthday to be the same, or the father's birthday is the same, or it's a special day for that. We want to synchronize these birthdays. Of course, the once a Caesar, always a Caesar, every doctor would not try. Very few doctors will do what we call VBAC, vaginal birth after cesarean section. Of course, this one, I emphasize it because as a urogynecologist, I do a lot of female genital cosmetic surgery. And the things that I hear women are going through, which I'll discuss later, made me to change my attitude to say, no, women cannot go through this because of childbirth, vaginal laxity. Let's address this maternal request nicely. This is influenced by the media. We're living in the era of the human right. They say it's your right. There are a lot of pamphlets in social media and the lay magazine that it's a woman's right to have a cesarean section. They say if you don't, you are not given the reason why you are not given cesarean section, they are violating your human rights. So women tend to demand that as their human rights. And they print fact sheets and everywhere to say that it's your basic right to have a cesarean section if you want a cesarean section. And with that, they pressurize doctors. I don't know whether obstetrics should change because of social demands that people are demanding cesarean section, because women read outside here. They say, you cannot deny me what I want. My body. It's not your body. It's your right to have a cesarean section. These things, they affect practicing of obstetrics. Of course, the one that I am a witness thereof is vaginal laxity. Just to take you through this process. You see, when the baby comes through during delivery, there will be, the head will dilate the vagina, the perineum, until such that the head comes out. The diameter of the head is about 9.5 to 10 centimeters. So during involution, the tissues don't go back to their normal length. You know, I always say a human tissue is like a rubber of poor quality. If a rubber is 10 centimeters long, you stretch it to 15. It doesn't stretch back to 15 when it comes, it's longer. And usually during crowning, if episiotomy is not cut early, there's overstretching of those muscles and they become lax. Hence, you have got a problem of vaginal laxity. If you expect somewhere where a 9 centimeter head has come out and during involution it doesn't, probably the diameter of the canal will be more. That's why it's inevitable to avoid vaginal laxity. That's why out there, nowadays with social media is propagated very quickly that there's a lot of treatment for vaginal laxity needed. I must say in my practice, there can't be 2 weeks where I don't do vaginal rejuvenation on any woman. They demand it. And they say they blame on a cesarean section. After cesarean section, the diameter of the canal becomes wider. And they want it shorter because maybe the partner wants it shorter. So they come for, there are a lot of modality, a lot of treatment, some proven, some are not proven, that its function is to make the vagina smaller. They call it vaginal tightening. So sometimes you can do with radio frequency, sometimes you have to stitch if there's been a tear. I found myself some 10 years back when I came to Petersburg having to invest in this machine, UltraFem 360, because this machine, it's non-invasive. You can do it in your room. It improves collagen formation and increases the thickness of the vaginal wall and nerves, and such that the vagina becomes tighter. We used to send people to Joburg, so I had to invest in this machine. This is how the machine works. It takes about 8 to 10 minutes to do the procedure. You put this machine, it uses radio frequency, which goes 360 degrees, and you do it for 10 minutes. And after 10 minutes, when you stop, after a few days, there will be increase in blood flow to that area. The vessels will be increased and nerve sensitivity will be increased. But after a month or so, the thickness of the vaginal wall will increase. And as the thickness of the vaginal wall increases, the vaginal canal becomes small, as you can see demonstrated here. That's the treatment that is, and it's not cheap. Vaginal laxity treatment is not always cheap. It's not everybody who knows is there. As doctors, we need this syndrome to take it into consideration. I take it into consideration when I treat women, so that cesarean section becomes the only way you can avoid it. By definition, when you say genital laxity or relaxation, it's a loss of vaginal integrity resulting from loss of tone of the vagina and strengthen the muscles and ligament that support the vagina. This is essentially weakening and dilation of the vagina with loss of vaginal integrity and distortion of normal vaginal axis for optimal vaginal function. Optimal vaginal function, I don't have to tell you, everybody knows what's the vaginal function. And during delivery, if this is the muscles for the pelvis, if you look at this, this thing is called genital hiatus or urogenital hiatus. It gets dilated. And if it gets dilated, some of the organs that are supported by the pelvic diaphragm, they protrude there. That's why I've got things like incontinence, prolapses, because of the damage that happened to do that. Previously, they say, what did our grandmothers used to live? You ask yourself, why was polygamy the mode of marriage? And when a polygamous marry, they don't marry them the same year. Nowadays, polygamy is regarded as emotional sexual abuse. And it's not allowed. The first wife will cry. So men resort to cheating. They call them pleasures. Because polygamy was one of the reasons was because of genital laxity. If you look at a polygamous marriage relationship, the first wife is always older, a few years older than the second wife. After the first wife has had 2 or 3 children, or even 4 or 5. And in a polygamous marriage where there are about 3 wives or 4 wives, the last wife is more or less the age of the firstborn of the first wife. So the age goes down and down. That's why if you look at this pelvis here, and you remove the skin from the perineum, inside here there are muscles. These transverse perineal muscles, the anal muscles, they coalesce here in the middle in the area called obstetric perineum. And these muscles, they can either overstretch or even tear. But because they're inside the skin, the doctor doesn't see that those muscles have ruptured. And then later we present with a genital laxity, which I said is a contributing factor. Even the nerves, they get overstretched, the sensation becomes less. I've shown you the urogenital hiatus, that if it dilates too much, the bladder that carries urine will fall. Most women, if they put a finger there, if they've delivered 2 or 3 children, they feel something like a ball, which will be grade 1 cystocele. But after menopause, with tissue degeneration, loss of estrogen, this bladder, usually, it protrudes outside the body. It's then that they can come and present. We see a lot of geriatric patients coming with cystocele. It didn't start now. It started while they were still in the reproductive phase. More often, the commonest one, if they've pushed too much big babies and dilated the urogenital hiatus, the uterus itself comes down. Most women, they can realize if they've delivered 1 or 2 children vaginally, if they put the finger in there, they realize that, no, it seems like I feel something that I used not to feel, which is nothing but the cervix. You find that the cervix is nearer, it's no more far. And as time goes on, it will come until it peeps through the openings, then that they will come. If a patient presents with grade 2 uterine prolapse, it didn't start now. She noticed it for many years and was wondering what it is. Until when she's old after menopause with tissue degeneration, she'll have prositatia, which is mostly, that's why they say genital prolapse is the disease of the elderly. It's not a disease of the elderly. We just see it more in the elderly. The commonest one is realize that elderly women, they tend to have a lot of constipation. People say it's because they don't have teeth, they don't digest well. It, of course, that can be a factor, but that is not the only factor. One of the factors why they have got constipation is because the rectum walls and come protrude through the vagina. When the fetal matters come, they bypass the anus and lodge there. And that's such one will tell you that I've got, after I've went to the toilet and evacuated, I've got this feeling that it's not completely evacuated. And there'll be a mess down there. I manually push upwards for the feces to come out. She has to manually push that rectocele so that the feces can come out. Of course, it's a milestone. They say it's a milestone. Most elderly women of about 80, 70, 80 who have delivered vaginally will have involuntary loss of urine when they cough, when they sneeze, when they carry heavy objects, such that they even retire from going to social gatherings. I'm no more going to funerals. I'm no longer going to society. I'm not, because of the damage that occurred during delivery. But all this because it's about genitals. Most women keep quiet. They don't even discuss it with the family. They just keep quiet. But women these days, they are emancipated. They've got rights. And it's our duty and the duty of this seminar to educate women on the long-term effect of childbirth and give them a choice, an informed choice. You know, there are 4 principles of ethics. One of the principles is autonomy, to exercise that autonomy. And I want to know, I put it in red because I think the experts will have to tell us more about it. Should we minimize the threshold for doing cesarean section at slightest provocation to a Caesar? Or should you stop worrying about cesarean section rate? I don't have the answer for those things. But as doctors, we are advocates of women. We love women. And most medical gynecologists, we treat women. We really have to come with some solution. And minimization of cesarean section rate, should we answer this question? The threshold for doing cesarean, the design, as slightest provocation, you do a Caesar. Or we should not worry if people say cesarean section is high. You know, I respect some people. Some people who respect women. I also respect women. I respect this man. He respects women.
Tell me here, is there a man who can say, I am not born of a woman? Let him raise his hand, let him raise his hand and say, I dropped from heaven. No, we all came through the same road. And
this is what we should respect women. We are born out of a woman. But one thing, the comparison, which the question that I ask and not giving the answer, cesarean section and normal birth, which one is better? If I was a woman, which one would I choose? Women, which one do women choose more often? I think during discussion, you will answer those questions. But the few questions that we should ask ourselves, which one is safe between the two, cesarean section? And we must define what is safe. What is safety? What do you mean? Because to me, every mode of delivery has got its own pros and cons. And which one heals faster? And you must define what is meant by healing. If it's pain that occurs during vaginal delivery, you say 2 hours thereafter the pain is gone, it's healing fast. What about pelvic floor distraction, which goes up to menopause? Is that healing or what? You must define what's healing. Which one has got long-term negative outcome on the woman's life? These days, in the literature, which the experts will tell us, why routine episiotomy is no longer recommended. Why is it not longer recommended? I'm asking questions here, not answering, because I've got people with more knowledge than me who can answer. And why women prefers sterilization than normal vaginal delivery? This one I've answered it. On my situation, majority of things is for genital preservation. The question is now, should women decide their preferred mode of delivery? If you were to take them into consideration, they say when you sign consent, you must explain to the patient, and this must be a joint decision between you and the patient. Should they decide? We're living in this era where many things affect medical practice. And here in South Africa, you know, there's this thing about women abuse. I don't know what it is. Women and children abuse. By whom? By men, you know? By men. But the breadwinners are abusers. There's a Proverbs by William Shakespeare, which says, many a true word is spoken in jest, which means jokes, songs often reveal underlying serious problem. If you find the songs people sing about something or a joke about something, there's an underlying serious problem. People usually frequently use humor to voice their thoughts and frustration or uncomfortable facts that may feel too awkward or intimidated to state quietly. That's why they say many are true words are said, spoken in jest. And there's a lot of emotional abuse when it comes to us. Emotional abuse, what I mean is when someone repeatedly tries to make you feel bad or unloved. Women after vaginal delivery, from my urogynecological perspective, the stories that they tell me, there are a lot of horrible stories that women are told by their partners at home because of they've delivered vaginally. Some of them, I can't say them here because they look semi-vulgar. Those lead to emotional neglect, which means withholding emotional support, affection, or attention, and leaving the woman feeling unimportant and loved. There are situations where there's withdrawal of intimacy altogether. You find that I have had women who came to me telling me that there's no intimacy in that house. My husband is going around with other ladies. When I tell her, she tells me about the anatomy of my genitals because I've delivered 4 children for him. That is worst form of emotional abuse. Should that affect obstetrics really? This genital laxity or vaginal loosening of sexual, because it leads to sexual deprivation, and genital laxity and sexual deprivation are deeply interwoven issues that impact physical intimacy and confidence and break families. Emotional abuse and sexual neglect abuse are severe form of maltreatment that can be inflicted on any woman and inflict deep psychological trauma on any woman. On that alone, I decided that if a woman is for that reason, I do a cesarean. But a question that I ask, which can normal vaginal delivery precipitate all the above emotional stuff? Can we blame it from normal vaginal delivery? Or can we say, can Caesarean section help positively in prevention of that form of emotional neglect and abuse? That question can be asked by the lay public because women there, they cry for help. They've got nowhere to go. They resort to songs and send messages. As we have said that Shakespeare said, many a true words have been spoken in jest. You don't say it directly, but it's said either in a song, in a recitation, or in a joke. This will lead to, I like the English is easy to say things in English, but Christianity just makes us that you can't say many things in our language. But the Southern Sothos, I like their songs. They've got deep messages. When I listened to this song, I thought women are neglected. There's a clinic called Men's Clinic where they look after men's needs. But I'm a gynecologist. I don't know women's clinic where they look at men's clinic. Even sexologists don't do that. Just listen here. Most people, the second part. The first part is cared for by the men's clinic. The second part, which means that many are true words are spoken in jest. This adage or aphorism or proverb has got a meaning, although it might mean jocular, and it is a public health problem. If we can hear somebody crying, even crying to God, you must know that thing is a real problem. There might be a song, a dance for it, but it says an underlying problem which is there in the community, which need to be addressed. And by whom? By us as professionals. But you know, in any relationship, most people these days with women emancipation, men are equals to women. And we tend to blame each other. This one blames the other one, this one blames the other one. But if we listen to many lyrics of many songs, we'll realize that many are true words are spoken in jest. Just listen to the end of this. Let's put this thing here because as a urogynecologist, you can't practice urogynecology without touching sexuality because most of the urogynecological problems, they impact on sexuality. And in training, medical training, we don't stress sexuality as such. Maybe the expert will tell us which discipline should treat sexuality. I think it's gynecology because we meet it more often. And women, because of frustration, there's a war of words between men and women. We find that they don't know where to go because this thing is not taught, it's not publicized. And only lay media publicize it, but not in a professional fashion. Listen.
Where did he go?
You hear what problems we had, what women tell us during consultations that we need to handle, which we must handle in a professional manner. But sexuality is not treated, is not taught at a very high level. Also, even in obstetrics and gynecology, I was once a lecturer. Our experts will tell us whether should we introduce it as part of the syllabus or not. Other indications that are true indications are like breech presentation. Breech is not in itself an indication for Caesar, but a big breech is an indication for Caesar because where the legs and the buttocks have passed, the big head might not pass because the head doesn't have sutures. There's no time for molding at the chin. So you'll have entrapment of the aftercoming head if it's a big breech. And other malpresentation, like if a child is obliquely lie, or is transversely lie, or is face to pubis, or brow presentation, or has got unstable lie. Tomorrow is like this, today is like this, in the afternoon is like this, or has got compact presentation. We'll show you those things as time goes on. Or maternal indication, when vaginal delivery is not possible, when there's cephalopelvic disproportion, or labor is dangerous to the mother maybe has got a heart disease that if he push, he might go into cardiac failure. With the advent of HIV, if it's poorly controlled, it is proven that it's better to deliver by cesarean section to avoid mother-to-child transmission. But if it's well controlled, the rate of mother-to-child transmission is not very high. So it's not an absolute indication. That's why it's important to control HIV strictly. If you've got a placenta previa major, a low-lying placenta that covers the cervical os, or if it's twin pregnancy, twin itself is not an indication. But when the first twin is not cephalic presentation, you must be very brave to deliver that vaginally, because not always you'll have that problem. But if you get a problem like locked twins, then I know you won't be able. You're either going to lose both babies or you're going to lose another baby. That's why if the first twin is not cephalic, most people will go for cesarean section. And then another thing that we want to tell you here, when the baby is delivered, the head must be well flexed. If it's flexed, the percentage diameter is what you call suboccipitopragmatic diameter. Below this occiput up to the anterior fontanelle is about 9.5 centimeters in length, and it can pass easily through the pelvis. All others, once it can deflex in a military position, the diameter changes to 11.5, which is occipitofrontal diameter. Or it becomes, it flex again, the diameter becomes from the chin to up in the head. It's called the brow presentation, 13.5. All these diameters won't pass through. That's why a face presentation can pass through if it's well, usually face to pubis, can present very well. These are the type of presentation I was talking about. This one in green is the one that you know that vaginal delivery is easy. All these others must be by cesarean section. If a lie is abnormal, the normal lie must be the longitudinal, long axis of the baby and the long axis of the mother must be parallel. If it's oblique or transverse, then it won't be able to deliver vaginally. Oblique, you can't deliver a baby by delivering the back first. It will not, unless in the case of a very small baby, usually a dead baby, in a process called corpus conduplicatus, then it can fold around, the baby can fold and deliver. But usually, this happens in intrauterine fetal death, but in live baby, you cannot do that. The other maneuvers that must be done with care is that if it's transverse lie, you can either do external rotation, either to convert it into a breech or convert it into cephalic. But you must do ultrasound and look at the placental position and make sure that you don't injure the placenta, because that might also precipitate bleeding in the form of placental abruption. This is the one of the military position. You can see that it can pass through the pelvis. That's an indication for cesarean section, because this diameter is about 11.5 centimeters. It won't pass through. And while in the face presentation, the diameter is small, it's 9.5, it can pass. But if it's face mental-lateral, it will have to rotate. The position that I wanted to tell you, just to see the difference, how the baby can take which position in the uterus. And that's when they say deliver by cesarean section, then you must agree. When we say position in obstetric, we refer to the fetus either facing backward or outward. And the part that we refer to called denominator is either is the occiput or is the chin, the bridge is the sacrum. So the obstetric language is, I don't want to bother you with it, but usually the most presentation that I've preferred are in a bridge or a cephalic presentation. It must be longitudinal presentation. This is a face presentation. They're going to deliver by the face first. But sometimes the face, mostly if it's the face is facing downwards, it can lock on the sacrum and not be able to come out. But if it's face to pubis, it delivers very easily and flex very easily. But even that one can be delivered. But the mal positioning and mal presentation is just an indication for cesarean section. It's an unfortunate situation where you find that a baby presents in two parts. The head is coming first and one of the limbs is coming first, usually the hand. The head and the hand are competing for the passage, which will not dilate this passage. That way, you have to do a cesarean section because you can't nip those hands so that the baby can withdraw the hand. The baby cannot withdraw the hand. And in a bridge presentation where it's kneeling, it's not a frank bridge, it's not a complete bridge, it's just an indication for cesarean section, although very rare. Other indication is multiple pregnancy of higher order. What do you mean? Triplets, quads, up is better to deliver by cesarean section. Why do you have to deliver the quads, triplets by cesarean section? Because after delivery of the first baby, the space becomes so big that the presentation or the lie of the other babies can change anyway, can either become oblique or transverse. So you don't want to deliver the first baby vaginally and the other babies by cesarean section. Another medical condition, which is if it occurs, it becomes an emergency situation when the premature separation of the placenta. If the placenta separates and the baby starts to bleed, That way, you have to do a cesarean section. I want to. Who is talking? Latin tool. Okay. Latin tool is fine. I'll remove it. If placenta separate prematurely, then there's bleeding. And if there's torrential bleeding, the baby might die, or even the mother might suffer the consequence of that intrapartum bleeding. In that way, you must do a cesarean section if there's such. If the placenta is in front of the baby, you can't deliver the placenta first and deliver the baby thereafter. It's called placenta previa. If you have got active herpes virus infection, genital herpes, you know herpes virus has got the evolution, it evolved with the people. There was herpes type 1, which was called labial herpes on the mouth. Type 2, they used to say it happens on the genitals. But nowadays, you find type 1 on the genitals, type 2 on the mouth, because of the patterns of copulation that happens these days, where people mimic animals and they lick the genitals playing. So you just call it genital herpes, or we call it genital herpes, or we call it we type it depending on what the laboratory will type it as. So if there's genital herpes virus which is active, the best way is to deliver by cesarean section. These are herpes warts. Some people call it fever blisters. If the baby can pass there and be infected with herpes, the whole body, the virus will destroy the whole body, and it becomes worse if it becomes disseminated herpes. The baby will have bruises all over, and this can affect even the brain and have herpes encephalitis. You don't want to have a baby like that. Once you see a 1-2 blister, cesarean section. If the multiple pregnancy of the higher order, I said, I mean triplets and quadruplets, that I said, once you deliver one baby here, vaginally, the space becomes so big that the lie and presentation of the other baby just changes. So you might be forced to deliver the first baby vaginally, and then you deliver the second baby by cesarean section, which by that time the baby is bleeding. So it's safer to do them by cesarean section. The maternal indications are many. The commonest one is if the baby's pelvis is too small for the baby to pass through here, or the baby has got a tumor in the pelvis, which impacted in the pelvis, or is a cancer of the cervix that you don't want to dilate it, or the baby bleeds during delivery from abruptio, from vasa previa, from whatever cause. The commonest one is uncontrolled hypertension, which is called preeclampsia. If it's so high that you think the baby will feed, because hypertension can cause convulsions, which is called eclampsia. The best thing is to deliver by cesarean section. Or if the uterus is just not contracting normally, you've got uterine inertia, you give it oxytocin, it doesn't, you do a cesarean section. Previous scar on the uterus, if it's on the upper segment. Scar on the lower segment, like all cesarean section, you can do a VBAC. It's not an indication. Although I said earlier on that the trend nowadays is that always, once a Caesar, always a Caesar, but it's not a genuine indication. If you have had hysterotomy, I'm not describing what cesarean section is. I said, if a baby is delivered before 28 weeks, it's called hysterotomy. The lower segment is not well formed. So inadvertently, when you cut, you are cutting on the upper segment, which doesn't heal very well. Or if a patient had abnormality of the uterus, such that they had to reconstruct the uterus, and maybe she has got 2 didelphys uterus with 2 horns or 1 horn, she underwent an operation. That operation will be on the upper segment, and the healing there tend to, even during pregnancy, tend to rupture very easy. And cesarean section, I mention it here because there are cesarean section where you have to cut on the upper segment by incision called delay. Delay start from the lower segment out to the upper segment. There might be indication where you have to encroach on the upper segment, or a classical incision or you only cut on the upper segment. The only moment why I did a classical incision is a patient who had renal transplant. When they transplant the kidney, they put it in the pelvis and they become a lot of vessels there. So the only way I had to cut was to go up in the fundus and do a classical cesarean section. That is an indication that the next baby must be delivered by cesarean section. If a patient had had a vesicovaginal fistula which was successfully repaired, the best thing is to deliver by cesarean section, because if it can happen for the second time, second VVF is very difficult to repair, if not impossible to repair. This is what I want to show you what a CPD is. If this diameter cannot pass here, then you can even pass a finger there, even after molding. That will be what we call CPD, because the maternal pelvis, although textbook says it dilates, the dilatation is very insignificant. Most of babies pass there because of molding. So cephalopelvic disproportion is one of the indications. If they say to you, the baby cannot pass here, your pelvis is too small, agree. Let's go tell you what to placenta previa. Low-lying placenta, where the placenta competes the space with the presenting part, because the presenting part should lie down, then it competes with the space with the placenta. It increases the chances of normal lie, because the baby will go, the head or the bridge will have to go on the side. This previa can be complete or partial. And during pregnancy, it's diagnosed by intermittent bleeding. At the lower segment form, it bleeds, it stops, it bleeds, it stops, it bleeds, it stops. That's why in such a pregnancy, they say you must abstain for the rest of the pregnancy. And if it occurs after viability, viability, I mean this, where the baby is viable, can live outside, say 36, 37 weeks, you must do a cesarean section. If it reaches term, placenta previa majority, placenta previa major, we deliver by elective cesarean section. Normally, placenta, the green part, is up there while the baby is going to pass through the vagina. It doesn't compete with that. But with some placentas implant low, it's type 1. In type 1, the only problem can be intermittent bleeding and stopping bleeding and stopping in pregnancy, but childbirth can occur. Although you run the risk of having intrapartum bleeding, which might force you to do a cesarean, but not much often. But type 2, it goes up to internal os. But with dilatation of the internal os, it might move to the side. The baby can pass you by luck. The only problem is what I've said, that they will be bleeding, but more often because of the head comes here, it tamponades that bleeding, but there will be separation. Type 3 and type 4, you can see it totally obstructs the baby. The baby cannot pass anywhere, and that is an indication for cesarean section. This, you can see it very easily even on ultrasound, when you do ultrasound, that this placenta is type 1 or type 2, type 3, and plan the baby that, look, we have to do a cesarean section because you've got placenta previa major.
Did you know that the placenta can sometimes block a baby's path out of the uterus? It's a dangerous condition called placenta previa, and it happens when the placenta, the organ that nourishes the growing baby, grows in the wrong place. Normally, the placenta forms at the top or side of the uterus. It grows above or beside the baby. But with placenta previa, the placenta forms beneath the baby. It ends up partially or fully covering the cervix. That's the passage the baby needs to travel through during birth. This can cause...
This is placenta previa. Maternal diabetes. I must say maternal diabetes. I forgot to introduce something, Ladies and gentlemen, among us here, we have got Professor Mahapa. I invited her just to be a spectator. He's not going to take part in the discussion, but I must acknowledge his presence here. Professor Mahapa is a diabetologist. He's got a PhD in diabetes. And he trained me. And in his unit, we treat a lot of diabetes there. So I must acknowledge the presence of Professor Mahapa here. But he's not going to take part. We will only have Professor, he's just spectating. He's just invited as a guest of honor, just to spectate as we talk. Diabetes tend to produce big babies, macrosomia. It forms big babies, but diabetic mothers tend to have very big babies, more than 4 kilograms. And those big babies tend to have cephalopelvic disproportion and increase in the incident of the condition called shoulder dystocia. I'll explain you it. And people tend to treat shoulder dystocia by applying pressure on the fundus. That procedure is very dangerous. I'm going to show it later. And diabetes is notorious by producing unexplained fetal death at term. When a woman is about 8.5 months or 8 months, the baby just dies. So when diabetes reaches term, deliver quickly. If it's macrosomia, Caesarean section. Because this is the shoulder dystocia. When the baby, the head comes out and the shoulders can't come out because the shoulders are usually wider than the head. And as I said, people tend to, when the shoulder baby is out, they apply what you call fundal pressure, Castellar maneuver. They push there, and as they push there, they cause genital injury, they cause tear of the perineum, and they cause many problems with that. This pressure that they put on the baby, you're pushing the baby, you can even break the spine, you can separate the placenta. The worst thing that can happen with that is what I'm going to show you later on, which is called Erb's palsy, where you can injure the nerve of the nerve that supplies the hand, as the shoulder is stuck here behind the symphysis pubis. And the big baby, if the shoulders are lateral, both of them will stuck behind the bones, and you can't be able to deliver that baby. So that's why a big baby in diabetes must be delivered by Caesarean section. See, this baby is 4.1 kilograms. You find a woman praising herself that I delivered 4.1 kilograms. We don't want to have a situation. We delivered healthy babies, not many babies, even if there are few, but if they are healthy, it's better. Let me show you what the problem of shoulder dystocia will happen. If a baby mother is diabetic, the baby is big, and she delivers, the head will come out because the head has got sutures. There's a process called molding, can reduce the diameter, present the diameter, but with rotation, the head, the shoulder tend to impact behind this bone. And if you push, with that push, we'll call fundal pressure, these nerves here, the nerves here, let me show you better again. If you push, the nerves that comes from the spinal nerves called brachial plexus, they get overstretched and get damaged. And that damage is a permanent damage. The child won't be able to use the hand anymore. It's called Erb's palsy. Let's see. You see, when it comes, if you push too much, you're injuring those nerves. And once you injure those nerves, the baby that's going to born out of there will be crippled. The hand won't be able to move anymore. It will be a baby which is called a condition called Erb's palsy because of brachial plexus injuries that occur because of birth. So because you don't want to deliver a woman with crippled because of the injury that happened during birth, we do Caesarean section. In a disparate measure, because sometimes you don't know that you're going to have a shoulder dystocia, the head comes out, but the shoulders are impacted. You can do something called, I've never done it myself, called Zavanelli maneuver, where you have to push the head backward into the uterus and do a Caesarean section, which is the last step of desperation to avoid the Erb's palsy that I've shown you there. Or you might have to cut the clavicle, the collarbone, cleidotomy, with a scissor and cut it. But when you cut cleidotomy, it's also is dangerous because behind the clavicle, there comes the vessels, the subclavian vessels are there. You might also cut them and cause bleeding. This is Zavanelli maneuver, where you take the head and rotate it and push it back inside and take the patient to theater to do a Caesarean section. Or you have to, while the baby is inside uterus, you put a scissor and break one or two of the clavicle to reduce that diameter. So you're causing a fracture. The worst situation is where you push suprapubically. Suprapubic pressure, you try to force that shoulder to go below that pubic bone. But in that way, one complication, which is orthopedics don't like, you might cause dislocation of that shoulder joint. So the best thing is to do a Caesarean section. There are many categories of cesarean section. Category 1 is emergency cesarean section. That must be done within 30 minutes. You must go, you must be in theater. Because things like if you have got a premature separation of the placenta, which is called placenta previa during birth, you must go there quickly because it will be progressive before it separates completely and the baby dies. Because if it separates completely, the baby will die. Or you've got cord presentation or cord prolapse. It's an emergency that must be treated immediately, because when the cord prolapses, something like this.
Another type of cord complication that can occur during labor and delivery is a cord prolapse. In this situation, the baby's head is not engaged in the pelvis. If the mom then has a rupture of membranes, it leaves an opportunity for that umbilical cord to fall through and deliver before the head. This is an emergency situation.
Cord prolapse is an emergency situation because another category is that are said they're urgent. There is maternal and fetal compromise, but it's not life-threatening. You can still wait for an hour, like if there's poor progress because of maternal exhaustion. The third category is scheduled cesarean section, where cesarean section is planned by the doctor and woman that will do it at a particular day. There is need for cesarean section. There's a genuine indication, but to plan it that will do it at a particular day. Or if there is a concern that if you continue with this pregnancy, there might be a problem in future with the baby, like in a situation where you have to deliver a patient iatrogenically, like controlled hypertension, in patient with diseases that warrant us to deliver prematurely because we anticipate problem with the mother or the baby. Like if amniotic fluid is small or is big, we suspect that the underlying problem might cause a problem in future. And others are elective cesarean section. These are planned by the doctor to suit the doctor, the mother, and the staff in the hospital. We plan that we'll do them electively. And when we do cesarean section, there are two types of incisions: the lower segment incision and the upper segment incision. The lower segment incision is done about 3 centimeters above the symphysis pubis. And these are incisions on the uterus, uterine incisions, where the upper segment incision above the level of the umbilicus up in the uterus. And the lower segment, the bleeding is not so much, but in the upper segment, it bleeds a lot. And the lower segment are the one that has got less chances of rupturing in the subsequent pregnancy. While if there's upper segment cesarean section, that's why there's no place for VBAC, because the chance of rupture is very high. So in lower segment cesarean section, you can do vaginal birth after cesarean section, VBAC, but there's no trial of SCAR or VBAC in upper segment incision. This is upper segment incision. This is lower segment incision, which is called DLE. It encroaches, it starts in the lower segment and go to the upper segment. The lower segment is transverse. DLE is only, classical is always in the upper segment. In that way, you can always deliver the baby. Like we're seeing here, if the baby is transverse, we won't be able to do. We might have to do a DLE or a classical. It's easier to extend, but it warrants you to do cesarean section in the subsequent pregnancy. There are different types of uterine incisions that are there, but the lower segment incision is the one that's more common. The classical uterus is cut on the fundus. DLE incision, I've said, the vertical is a vertical lower segment, which encroaches on the middle or the upper segment. The lower transverse cesarean section is the one that is recommended because the uterus is cut low down where it's thin and curved downwards and heals very much better. The truflar incision, very rarely done. It's also a lower segment incision. Munro-Kerr incision is curved downwards. Usually Munro-Kerr incision, you don't do it by default. It's only when the lower segment incision is not enough for the baby to come, you decide that you're going to curve downwards or you're going to curve upwards. If you curve upwards, it's called Bailey trapdoor incision. You usually curve bilaterally or you can do a Y or a T incision, which are not planned incision, are incision that intraoperatively you decide, let me do it. Like a lower segment incisions like this. This is a Munro-K incision. This is a trapdoor incision of Bailey, Y incision. There are many incisions that you can do. As I've said, the lower upper segment incision the upper segment is very thick. And if the baby doesn't come, you can have to make a T incision or a Y incision. The incisions on the uterus differ from the incision on the abdomen. The commonest previously used to be a vertical midline incision. We start from the symphysis pubis upwards towards the umbilicus, just below the umbilicus. But with evolution, women don't like it. Nowadays, we put cosmetics into the operation. We do horizontal incisions. And the commonest of the horizontal incision is what they call funnel steel incision or dual coil incision. They're more or less similar, more or less the same place. Although funnel steel is curved, dual coil is straight. The Maillard and the Chinese incision are not obstetric incisions. They are for gynecological incision for tumors, big tumors. But obstetric is dual coil and funnel steel predominating. These are the incisions on the abdomen. The funnel steel is curved just above the symphysis pubis, and usually in the pubic hair region. It can be hidden in the pubic hair. They call it beginner's incision. The women like it very much. While dual coil is slightly above, but is straight. The Maillard, I've said that it's not used for gynae incision. We usually use funnel steel incision, which is just above the hairline, or if the hairline goes up, it can be within the hairline and be hidden. This is the funnel steel incision as compared to midline subumbilical incision. Women don't like this incision these days. They'll say, doctor, how are you going to cut me? If you say midline, they say, hey, I don't want that one. They forget that for you to go through Caesarean section, it's not as easy as that. You go through many layers. You cut about 8 layers. The skin, the subcutaneous fascia, you've got 2 fascias, scapa and campa fascia. Cut the rectus fascia, the rectus cyst, the anterior leaf of the rectus cyst, because on the lower segment is only the anterior leaf, there's no posterior leaf. And thereafter, you still have to cut the posterior leaf of the rectus cyst if it's a midline longitudinal, because somewhere between the umbilicus and the symphysis pubis, the rectus cyst is both anterior and below the rectus muscles, but with funnel steel is only anterior. And you go to preperitoneal fat until you cut the parietal peritoneum. You see 8 layers that you've got to go through to cut. And when you suture, you must suture them all upwards. So the issue, I did a Caesar fast. I always tell doctors, there's no races in doing a Caesar. You can't say I did a Caesar fast because you've got to do it properly and take your time and do it. There are a lot of preparation that must be done before you do a Caesar. They must test your HIV status. They must test your renal function, whether they are good, and they must also go and test your hemoglobin estimation, whether you will be able to carry oxygen. Of importance is shaving. That's literature changes, obstetric changes. That's why I put it in bold here so that our expert can see it. Pubic hair shaving in lower segment incision, like funnel steel and dual coil. Is it necessary or not necessary? I want to be a devil's advocate. It depends on the pattern of the escutcheon. But when you put policies, you don't put policies for every pattern of the escutcheon. What is an escutcheon? In a medical term, escutcheon refers to the pattern of distribution of the pubic hair on the human body, how the pubic hair is distributed. The pattern typically differs between a man and a woman. In a female, it forms an inverted triangle with the base of on the top and the apex pointing downwards. In a male, escutcheon, it's either an upright triangle or it's diamond shaped. It goes towards the navel. These are the 2 escutcheons that we do. And we say we're going to cut incisions. Depend on, when I say it depends on the escutcheons. When you put policies, we don't know which patient are going to come. Some women has got a male distribution of pubic hair like this. It doesn't mean it's a male, it's just a male distribution. It goes up towards the umbilicus. while a typical female escutcheon is like this. And if you have to make incision, say you want to make a Chinese incision, there's going to be an area where you can't cut through the hair. And if you haven't shaved, you're going to find cause inclusion cysts here because hair are going to be enclosed inside your incision. Or if, for instance, you want to do a fine and steel incision, majority of or all the incision will be the hairline. Or if it's Joel Cohen, still it's going to traverse through the hairline. But if it's a female, also, the fine and steel incision will go through the hairline. And majority of the scissors that we do through the fine and steel incision. You can't do a Joel Cohen because you are afraid of the pubic hair that is not shaved. Of course, with the male it will be up. So that's why I said, this thing of saying it's not necessary to shave, is it evidence-based? The expert will tell us. Preparation for cesarean section is start with discussion, anesthesia, the feeding option, until you obtain your consent. I think the consent, when you obtain it, the father must always be there because this pregnancy doesn't belong to a man, so that they must understand what's going to be. After providing adequate evidence-based information, she must then sign a consent. And you must take the culture and the social class of the people into consideration. Don't be too bombastic on somebody who's from behind the mountain who is not learned. Take also the clinical situation. Although the consent of the father is not necessary, the husband is not necessary, but for decency, let her be part of the consent. The things that this is patient's right. There are many rights that really are wrongs. Some rights are not patient's rights, they are wrongs. Because there's another right which says patients have got the right to refuse treatment. The type of anesthesia that you're going to have, you have to discuss. Ideally, it's the anesthetist who should discuss this, because when I was still in Pretoria, anesthetists used to have, that way Adobe for me, had consulting rooms where we send patients there on particular day. There's always one there who explain to them what's anesthesia, what type of anesthesia, what they are going to do, and assess them thoroughly pre-examination. But since I came here around, I see anesthetists are just moving like smoses. The offices are in the car, and I encourage them to open an office so that we can send and they can examine patient there. There are two types that we usually use for cesarean. General anesthesia, where the patient sleeps, become unconscious. It's not dead. The patient asks me, will I be dead? You are not dead. You are asleep. Or regional anesthesia, where they block the nerves from at the level of the umbilicus downwards. You don't feel anything. But outside, you can be awake. You can experience the birth of the baby, and you can have immediate contact with the baby. I prefer the father to be present in theater, usually if there is a regional anesthesia, so that he also be part of that experience. Preparation is a must. Before the patient goes to theater, must be examined by the anesthesiologist, not in theater, in the ward, so that if there's anything that needs to be changed, must be changed there. If the anesthetists feel that the heart murmur, there's a heart murmur there, I need an ECG. You must do it there. If we need to postpone for some time, we need to postpone there, not to cancel the patient on the table. Because if you cancel the patient on the table, you are disappointing the patient and the doctor. And the doctor is the doctor of the patient. It means you won't be good friends. And you'll be given medicine to neutralize your stomach acids. Whether you're starved or not, you are not starved, you need no neutralization, because with pregnancy, the valve that between the esophagus and the stomach is poor. It's called, then you could easily get reflux. Then the medication that makes you lose amnestic, so that they alleviate anxiety, because theater can scare very people. You go to a place when people are in green, they've got masks, there are lights, you've never been there, they get very much scared. But if they're given this amnestic agent, which usually are the benzodiazepines or butyrophenones, you go there not knowing what's going there. Of course, this one, we want to show whether is it necessary or not. I gave our experts will tell us. The thing that women start scaring them is that when you arrive in the ward, the first pain that you have is that of a drip. It's either given by the sister in the ward, or the doctor in the ward, or the anesthesiologist. It's for giving you medication. I prefer this to be done in theater, unless in a situation where there's going to be regional anesthesia, where they want to preload the patient. Even in that case, it will take about 10 to 15 minutes to preload the patient. We can wait, but to do that in the ward, it just bring fear into the patient. In this place, they are going to injure me. But it's a mandatory that you must have an IV line before you can go anesthesia, because anesthetic agents are going to be given through that IV line. Regional anesthesia, what is regional anesthesia? They block the nerves from a certain area. It lasts about 4 to 5 hours. And during that process, the anesthetist is going to pass through many layers. The skin, the subcutaneous phase, supraspinous ligament, ligamentum flavum, epidural space, dura mater, subdural space, arachnoid, and finally arrive at the subarachnoid space where he's going to put that thing. And usually he puts it while you are sleeping, although some anesthetists put it while you are lying down, and the needle passes here until the anesthetic agent is put there. Very rarely do I see them in pregnancy putting them lying down, but in other procedures they put it that. I always tell my anesthetist to look, explain to these people, why don't you have videos or links that you can send to the patient? They know what we have done, because they don't know what we have done. Later they come to me, they ask me, I have got to explain anesthesiology. So that in my rooms, when you go for CISA, I send you this link just to make life easy for the anesthesiologists, because they don't have consulting room. I'm talking to them, they must have consulting room so that they can explain this thing. It's a sterile procedure, regional anesthesia, where they prepare the anesthetic agents and inject the area with, they numb the area with analgesia, so that when they put the needle in there, you don't feel pain. And thereafter, they inject the agent in there. In essence, what they do, the link that I send my patient usually is this one. I send it that, tell her that it's a sterile procedure in theater. Everything is cleaned, no chance of infection, and you will be disinfected with chlorhexidine, and everything is from the sterile environment. Even their anesthetists will have scrubbed, and from there they are going to put this needle on you. They'll mark the area thoroughly, knowing that at this level we want to block you, and then they inject you firstly with local anesthetic, so that when the needle passes there, you mustn't feel pain. And thereafter, they're going to put that long needle, which is a guide needle. It guides the longer needle. And then from there, they'll put the longer needle, which will go up to the subarachnoid space, and see if they're in the right space. They will see the cerebrospinal fluid coming out. They wait and see if it comes out, and see that the fluid is coming out. To avoid air bubble, they wait until one drop comes out. And the first thing they do, they pull out. If they pull in and blood comes in, they don't inject. Because if they pull in, the blood comes in, it's called a bloody tap, which is called xanthothromia. And the pulling up is called babutage. Then they inject. It works immediately. I always tell anesthetists that explain this thing, the difference between regional and general anesthesia. I found that I was still in Pretoria. I found that people don't know what's going to happen, and anesthetists just explain in bombastic way. I made 2 videos like this, which I play to the video, and I put them on my YouTube channel to explain to the patient and the public what is general anesthesia.
An operation, the patient is being prepared to sleep. The anesthetist is getting ready to put the patient to sleep. The anesthetic machine. The nurse is calibrating the anesthetic machine. While on the other hand, the instruments are being opened, and the scrub sister is getting ready to prepare for the operation. Patient is well relaxed. The fluid that's being injected into the patient is propofol. It's going to put the patient to sleep. The anesthetist continuously talk to the patient and engage with the patient as he put the propofol into the patient. You can see very well that almost the whole syringe is going into the patient. It's finished. The patient is now ready to sleep. By now, he should be unconscious and sleeping.
This is one of the videos that I made. I put it on my YouTube. Most anesthetists use this video because I couldn't find any other one on the YouTube. And then it says that it explains exactly what's happening inside theater, from instrument count, swab count, which the swab they count in multiple of 5, and all instruments that are open are counted before and after, so that we mustn't leave. Ensure that there's no swap of an instrument that's left inside the patient. And that swap count must be loud so that everybody can hear what you're saying. In the meantime, the anesthetist, on the other hand, after putting propofol, must assess the level of anesthesia. You mustn't intubate or cut when the patient is half asleep. And assess the patient whether it's intubatable or not. It's easy to intubate. Although this would have been assessed in the pre-anesthetic evaluation, it's repeated again when the patient is asleep, because you can look at the airways very well and look at the accessibility of the airways by the anesthetist before intubating.
Now the team is getting ready to intubate the patient so that the patient can breathe through the machine, which is a ventilator. The mask, which is held on the patient's mouth, is giving the patient oxygen and some inhalation agents. The anesthetist now get ready to intubate. Tube is put through there with the pipe, and the patient is now ventilated, fully dependent on the ventilator.
Then, as everybody becomes busy in theater, as this one, as that is sisters are doing, counting the instruments, others scrapping, the surgeons must also be ready. I used to be assisted by a very good assistant called Dr. Muledi. Must be ready, preparing.
The doctors are making sure that they are clean, their hands are clean. They call it scrubbing. I'm using povidone iodine and Dr. Muledi, my assistant, is using it scrub. Hello. Like this. Making my hands outright. Four.
Then from there, this is what I usually give the anesthetist and the patients this link to see what cesarean section is like. And the techniques of cesarean section, although they differ from person to person, but usually it follows that you cut the skin, you cut the uterus incision in a preferred manner, you scoop the pacing part out of the head and you deliver the baby and you suture in a standardized manner. In that way, the way you were taught, the variations are not that much. The techniques follow the same pattern. The incision that's more common, I said, is Van Steed, which is an incision which is pioneered by the man called Herman Johannes Van Steed. It's an incision of the lower abdominal incision that provides access to the pelvic organ, particularly the bladder. It's even used in gynecological and make a very beautiful scar called bikini scar. This Van Steed was a German gynecologist, was born in Berlin in June 1862. He died in the 3rd, 1992. The funniest still his history is that he received his medical degree from Berlin and became the head of obstetrics and gynecology in the University of Gießen. From there, after 10 years, he was transferred to Kiel University. I like Kiel University because I studied there. I went there for my endoscopic study. But by then, the head of the department was Professor Medler, who was succeeding Sam. Sam is S-E-M-M, Cat Sam. Cat Sam is the founder of serratic edge micromodulator that is used in endoscopy. That Sam is a surname. The thing is an acronym for serratic edge micromodulator. It's the same name of the person who discovered it. And unfortunately, Van still died of infection at the age of 47 while doing it. Died from sepsis after cutting himself, injuring a finger during the surgery for tuber ovarian abscess. That is before Semmelweis can come with the issue of scrubbing. Surgeons used to wash without scrubbing until Semmelweis came with us with the idea of scrubbing in antisepsis. I've put a video of Semmelweis on my WhatsApp status, those who can go through it. Surgery used to be done without scrubbing. This is the man, Van Steele, who came with this incision, which is very much popular, and we all do it. It's done in a manner that you cut. If you look here, you think it's straight in mine. It's not straight, it's curved. Because I pull the skin upwards. When I leave it, it will be curved. That's a Van Steele incision that is been done. It's a commonest abdominal incision that's cosmetically appealing, and it comes inside the panty line. You can't even see it when you go for a gym. It's a very good appealing incision. They used to say when you do fine and steel, you must be very careful because you're looking for cosmetics. If you don't look at the landmarks very easily, you end up with a skew fine and steel like this. The woman will hate you for the rest of his life. I usually put my fingers on the anterior superior iliac spine to get the symmetry. Then I pull the abdomen forward. Once I pull the abdomen forward, I cut straight. When I cut straight, when I leave that abdomen that I put upwards, it becomes straight. You see, my hand pulled the abdomen upwards. Then I cut just straight. And when I'm going to leave it, it's going to be a curved incision in that way. Some people just curve it by themselves, but I find that if I curve like that, I end up not having a symmetrical incision. But if I curve it around, I've got a good symmetrical incision that even my patients appreciate. After I've cut the skin, then you cut the rectus sheath, which is the toughest layer that support the abdomen. The rectus sheath doesn't bleed as much as the skin. It's whitish, and as I said, on the lower segment, all three layers of the rectus sheath for the three muscle layer, which I'll show you later, they come anterior, so it's very tough. I extend it usually with a scissor because you can't extend with the hand. And then step by step, as you enter the abdomen, you take care of the cosmetic of your things thereafter, and you tie all bleeders so that you mustn't have a hematoma. There's no need for using Caesarean Cesarean section. Some people use it. I find no need for using it. The assistant can keep the field bloodless. You can tie all the bleeders that are there. There are not many bleeders in cesarean section. You can anticipate some bleeders. There'll be some superficial bleeders. You see, you cut here. It doesn't bleed as such. You can just mop them. There'll be one or two bleeders that are deep that the assistant can just mop, and you go until you reach the rectus sheath. It's not bleeding that it can say can exsanguinate the patient, and until you find that the rectus sheath, which is formed by the aponeurosis of the three abdominal muscles, which is external oblique muscles, internal oblique, and transversus abdominis. When they come to the front, they form a bloodless ligament-like structure, which is called aponeurosis. And midway between the umbilicus and the phyphysis, that aponeurosis, it covers the rectus only anteriorly. That's where you're going to cut. But as you go up, it covers anterior and posterior. So in the longitudinal incision, you reach an area where you have to cut the rectus is anterior leaf and the posterior leaf. But with fine and steel, it's only the posterior leaf that covers these muscles, which is we call rectus abdominis, which is the muscles of the six packs, formed by the three muscles, rectus abdominis, transversus abdominis, external abdominis. They cover all this. The three muscles below, they form an aponeurosis that covers the strap muscles. Like here, below the aponeurosis comes to front. As you go up, the internal oblique, it divides into two, and there's anterior leaf and posterior leaf, and the internals, it only in front. Only external oblique is in front. But with fine and steel, we only cut here. So it becomes easier to cut, but you anticipate a more tougher cut, and you must have a good sharp knife so that it's because the rectus sheath there is thick. Then you need to cut very deeply to reach it. And once you see the whiteness, you know there's the rectus sheath, then you can cut it easily. It must demonstrate what the rectus sheath is. This is what protects all your abdomens and everything. All the skin is just cosmetic. The rectus sheath is that whitish, hard layer that you can extend with a scissor, extend enough for the baby to come out, which, as I explained, that is formed by the three layers of external, internal, and transversus abdominis aponeurosis to form in the rectus sheath, which somewhere between the umbilicus and the pubis, it covers anterior and posterior, but below where you cut, it's only posterior. The midline between the two strap muscles is called linea alba. The two rectus abdominis muscles in the midline, they're called a linea alba. Here is green. Linea alba means white line. And below, there's another vestigial muscle, which is useless muscles. It's called pyramidalis muscle. It's got no function now. They say it used to function when we were still quadrupeds, when human beings used to move with 4 legs, but now it does not. So after you have entered the rectus sheath, then the next layer is to separate those two rectus muscles and the pyramidalis. And if you come right in the middle, it's bloodless. You won't find any more blood. Very little you can find some blood there, which is just a capillaries. But thereafter, after separating, then you reach the peritoneum there. The peritoneum makes sure that there's no abdomen. Incisor is good because the uterus pushes all the intestines up. You're sure that you're not going to find anything, and you cut just a hole, the air will go inside, then you see a uterus. The incision usually extended can extend with a scissor or just by pulling with hands. I prefer to pull with hands because with hands, if there are vessels, I just push them apart. And then that way, I've got minimal bleeding. Then you can enter the abdomen after separation, the strap muscle, which are the rectus muscles. And then the vertical incision on the parietal peritoneum is what I've shown you later. But now incision on the visceral peritoneum is transverse. Visceral peritoneum, it covers the uterus and the bladder. Because why you have to dissect the visceral peritoneum? Because you want to push the bladder downwards so that during incision of the lower segment, you don't injure it. And then you make a transverse incision on the lower segment. You first cut the uterus until you reach the membranes. This, all what I explained, will be visualized here. The rectus muscles, you separate them by just pulling. I prefer pulling. You must have eaten when you go to the scissor. It's not easy. You need some force. Pull apart. And you pull apart all the potential bleeders, you put them back. And then, because when you're going to cut the uterus, there's going to be blood. There's going to be amniotic fluid coming in. And that is likely to fall into the abdomen. It fall into paracolic gutter and fall into annexal gutters. To avoid blood and liquid falling into there, you put a PEG, you pack some swabs inside there so that if blood goes there, it blocks there and it's absorbed by those PEGs so that when you remove them, you don't have much blood left inside the abdomen because blood can cause irritation, can cause pain, can precipitate adhesions, and adhesions can precipitate tubal blockage. In that way, you can cause infertility, subsequent pregnancy. You need to protect blood, especially like from going into there. And this step is very important in the sense that if it's an emergency, you might forget this swab inside. So every swab has got an artery forceps here to mark that this is a swab. And then the final steel incision was criticized for the fact that they said it doesn't give enough exposure. The only exposure that you need is the uterus. You don't need exposure for other things. So they say it takes longer time to deliver. It doesn't. I find it doesn't. Because the time to deliver from skin to baby depend on the speed of the surgeon. Some slow surgeons are slow, some are fast. So it means slow surgeons shouldn't do Caesar. And as I said, I find the final steel and up and down the same. I've stressed the importance of packing the pelvis because if you don't pack it, you'll cause irritation. But if you pack, you make sure you don't leave it in the abdomen, you mark it with an artery forceps because this is one of the commonest lawsuits that come. They sue if you leave it inside. And then once you are inside, you pack like this, as I'm stressing it again, mark it with something, with an artery forceps so that there's no chance that this tail, this green tail, you put an artery forceps there. So there's no chance that you can leave it inside here. Because if it's just like that, that green tail can just go inside. And because maybe because of anxiety, you see, that's how I mark it. I put it and mark it. In that way, you can't leave it. Because if you don't mark it and you leave it, oh, the lawyers are out there, they are hungry. They're going to sue like anything. The patient these days, they like suing. I don't know why they like suing. So I always pack the abdomen with arteries, with the pegs and mark them with arteries so that when they count them, they're out. I've seen a situation where the swab count is normal and then suddenly you've got a medical legal problem where a swab is left inside. One of the problems that you can have in cesarean section when you cut, that's why it's such a delicate scissor that you mustn't cut the baby. That knife is very sharp and you mustn't leave the swab inside. Swab inside the baby is called texiloma or gossipiloma because people gossip about you if you dare cut it. And that green tail that you've seen there is radio opaque. You can see it through the x-ray. If the woman after cesarean section presents with pain, mild ileus, abdominal distension, you do an x-ray, you find something like this. This is the tail of the swab. That's swab that's left inside. It's this green part of the swab that is there, which can be left. But more often we ignore that signs. The swab can form adhesions there and cause problems in perforation. The incisions on the uterus is transverse, as I've said. You need a good exposure and you cut the period. I like, if the lower segment is well formed, I like using a scissor because with a knife you can cut the abdomen. I like using a scissor. And then suddenly I see the hair, then you can see the head of the baby and enlarge the incision with just manually pulling. And that way you will be able to deliver the baby easily with an increase. Even in a bridge presentation, you can see, if manually, you can see the buttocks of the baby and you can enter the womb. And once you enter the womb, the first thing, the membranes, if they are still intact, the amniotic fluid is going to come out. And it can come out under such high pressure that it can splash you. So you must be very careful. And you scoop the head out of the pelvis and deliver the baby and clamp the cord. I prefer the cord to be clamped by the father, but in private, they agree the father to come in. In state, they don't agree the father to come in. I don't know why. So in that way, when you start cutting the membranes, the liquor will splash out. Once the liquor splashes out, I usually use a blunt scissor, that's liquor splashing out, and then enlarge the incision and scoop the baby out if it's not engaged. If it's well engaged deep into the pelvis, you might have to ask the assistant to push from below so that they can dislodge the baby out of the pelvis and you deliver it out. But in this one, as elective, the head is still floating up. We just put the right hand and scoop it. With or without the assistant help pushing, the baby will be coming out. And some babies, depending on how they are, some baby come out very well and cry. Some baby come out distressed, depending whether it's emergency or elective or the cause for seizure. Like you see this baby here, it comes out, it starts crying, it's got a moral reflex, the hands are going up, and the mother and the baby are happy. That one, you don't have to do anything. You know that this baby will breathe very well, and you ask the father, if he's around, to cut the cord, and that he will remember for the rest of his life. In this case, the father is the one who's cutting the cord. I just separate and show the father where to cut the cord. I give the father a scissor and he cuts the cord. Because I always say that he's the one who joined the two. You must separate and you give that to the pediatric staff who will look after the baby while you look after that. It's not always the case that the baby will come out normal, crying. Sometimes you deliver, you give the father a scissor, you expect the baby to come, and it becomes an emergency, and you think it will depress the father because the baby comes, is flat, it doesn't cry. You have to start resuscitating there, to suction there, and elicit reflexes there. She's blue, and if the father cut quickly and give the pediatrician to go and give oxygen, because if this baby is flat, it's not like the previous one. So you can never know what to anticipate. But to deliver the baby, you scoop the head out. I said if it's deeply engaged, the assistant might have to push from below. And the assistant sometimes, if after cutting, must be elective if there's no contraction, you might have to ask the assistants to push from to push a fundal pressure so that and push then push so that the baby can come out after scooped it, because otherwise you scoop it and it just stays there. Like you see here, I ask here the assistant to push. I'm scooping it, the assistant will push that way to come out because the baby was not coming out. So it's not always that the baby will come out, but if she has been in labor, the baby will definitely come out. And in this case, you see the cord is around the neck. If the cord is around the neck, it can strangulate the baby and deprive the baby of oxygen, and you have to turn it around and clamp the cord. Still, as a matter of fact, I asked the father to cut. And after that delivery of the baby, you must deliver the placenta and examine it thoroughly, the maternal and the fetal side, whether there are no cotyledons left in there, because that will be product of conception left there, and they can get rotten in there and cause infection. That's the placental delivery. After delivery of the placenta, you let the blood comes out so that the blood must not splash, because that blood is under pressure. Then after delivery of the placenta, it must be examined and be confirmed that all the placenta and the membranes are out. If the placenta and membranes are all out, then you are happy that everything is fine. One thing that I wanted to stress here, which is an avoidable complication, is cord complication. There's no need in the modern obstetrics to deliver a baby with a cord around the neck, not knowing that the cord was around the neck. Because like in here, if the cord is around the neck, because that cord around the neck, you would have seen it during sonar. Immediately before delivery, the patient must go through sonography, and you tell her that the cord is around the neck so that you anticipate it. Even in a vaginal delivery, if the cord is around the neck, you sew it and it doesn't cause any problem. You can conduct that labor. After conducting that labor with the cord around the neck, and then later, when the patient is delivering, before she delivers, you put your fingers inside there and remove the cord from around the neck, because it's only during delivery that the cord is going to squeeze the neck and deprive the baby of oxygen and deliver it easily. I have a story that I have to tell, which I'll never forget. I get a woman, it was the second baby. This woman, I saw the cord around the neck. And I told her, I said, look, you are 38 weeks. Let's deliver you now. Let me deliver you by Caesarean section. I was very careful. She said, no. She went home. She said, no, I want to deliver normally. I delivered the first baby normally. I said, fine, you can deliver normally with the cord, but it's around the neck. And after 2 days, she phoned me and said, I was still in Pretoria. I can't feel the baby's movement. She came. I did a sewn, cord was around the neck, and this is what I delivered. I can't forget this woman because the cord was around. I saw it. I wanted to prevent it, but I couldn't. But majority of cord around the neck, you can see it in 3D to avoid calamities where you find the patient has got. Even in 2D, you can see if there's cord around the neck. Here, you can see that there's a cord around the neck. Convert it to the 3D and see a cord around the neck there. Then when doing a sonar, thorough sonar, you should be able to see everything. And at time, examine the cord around the neck. So of course, that's where you'll do your Dopplers on the cord. This one, you see, the cord is going that way, but it's not around the neck. It depends on which direction the baby will turn, whether it will be around the neck or not around the neck. This one, the baby is holding the cord with the hands in a 3D fashion. The aim of ultrasound is not a photo. People come for photo, they want to see how the baby looks like, and we give them photo. The aim of ultrasound, although it can tell you the gender of the baby, the aim is not to look for the risks and mitigate the risk. You can see whether it's a female or female, but that's an added bonus. You must check even for the congenital abnormalities like a spina bifida. When they do ultrasound and charge you, you must know they're doing many things. And after delivery, you need to suture everything. You might need to suture everything, the layer by layer. Once you go down, you suture everything, and you bury the layer. The first layer, you suture, and the second layer, bury the second layer. That way, you will be able to suture. Like you see here, when you suture the uterus, you suture the first layer. The second layer, you bury the second layer. You can see the needle here. It goes in, out, to suture the first layer, buries the second layer. So and oh, so you suture the whole uterus, and the baby you give to the pediatrician to look after. So it must assess, take the first weight of the baby, which is the birth weight, there in theater, and then thereafter they take the baby and put it in a warm environment and assess the baby's developmental, the abnormality, whether there's congenital abnormality or not, and report to you how the baby. In the meantime, the surgeon will be suturing the uterus. By the time the pediatrician finishes, the surgeon will also be finishing. And the technique for closure can be surgical, can be staples, can be anything, can be a bandage, depending on the choice. There are many things that you can do. There are many ways you can suture the abdomen, but provided you do not leave a dead space and cause a hematoma. Because at the end, you want a good cosmetic wound. It doesn't matter whether you do subcut or not. If the healing pattern of the patient will determine the type of scar, you can make a very beautiful wound. But the woman, when she comes with a scar, with a keloid, hypertrophic scar. Although you anticipated a good scar like that one, depending how you heal, some people heal very badly, and there's nothing you can do. Even plastic cannot do anything about it. But the technique for closing the abdomen, as I've said, is a backward as you stand. You start suturing the parietal peritoneum. That's after suturing the uterus, the parietal. You go up from parietal, you oppose the muscles. From there, the rectus sheath. The parietal peritoneum is not such a strong thing. You just suture out. The sutures can be 2 centimeters, 3 centimeters apart, 1, 2, and you finish. And after suturing the parietal peritoneum, then you must oppose those muscles, the rectus muscles that you separated. Because if you don't oppose them, you'll see what the complication is going to be. That's the parietal peritoneum is sutured. Then from there, you need to oppose the rectus muscles. You pull them, you pull them to put them midline. Those are the muscles that you separated, because even in pregnancy, they would have been separated. You avoid a condition called diastasis recti. Although the skin for putting 2 or 3 sutures are enough, because you're not suturing them tightly, you just put them in the right place so that when they heal, there shouldn't be a hernia there. Because normally, during pregnancy, there are changes that happens in these muscles. They separate, you know. When the abdomen distends, they separate and call what you call diastasis recti. In a non-pregnant woman, it's like this. In pregnancy, they are separate. So you want a woman, you don't want a woman after pregnancy to have a sort of a midline hernia like this. They don't like it. So you want a woman who is well like that one. Like I want to demonstrate it.
Stretched. As your baby and abdomen grows during pregnancy, the rectus abdominis muscles, or the 6-pack muscles, are stretched apart, causing a vertical gap down your midline. This is a normal and healthy part.
As you see, during pregnancy, they will be separated.
Your baby.
So if you don't suture them, you're going to have an abdomen which is like this. So this woman won't like, because they want to expose they want to put stomach out these days. You must approximate the rectus muscles to avoid diastasis recti. That's why always is necessary to have this step where you pull the muscles together so that cosmetically the patient can be well. And then thereafter you suture the rectus sheath. You suture the rectus sheath that you have cut. Now you must suture. You're correcting what we have done before. And this is the suture for the rectus sheath on the right. On the left is when you're cutting. Then you suture with a strong suture material so that this is the strongest layer that you can have to support this baby. Until you finish suturing, once you finish suturing, you know that everything is inside. You have sutured completely. Then you go to the subcutaneous fat, which I said is scapa fascia. You approximate to avoid a dead space formation during that fat, subcutaneous fat, so that if it's too big, you can even put a drain in the subcutaneous fat, so that otherwise there will be a dead space and the seroma will approximate there. I usually put it in 2 or 3 layers, the subcutaneous fat, to suture continuously, either from myself to the assistant or from assistant side to myself. It doesn't matter as long as there's no dead space. And then from thereafter, you can finish with skin suturing with the material of your choice, tissue-friendly material that will not cause hypertrophic scar. As I said, every woman heals his own way, but I like the tissue-friendly tissues. I won't mention name because here I'll be advertising them. But nowadays, the skin sutures are tissue-friendly. If you put it nightly subcutaneously, they give you a very nice wound. I find that a very good wound, which when healing is cosmetically appealing, such that the patient will appreciate to have a skin suture like that one. So I think if suturing well, avoid complications like wound dehiscence where the wound will open. And the type of suture, if it's good, you won't have a wound because the wound can open in such a way that intestine can even come out. You have evisceration if it does suture well or the suture material is not a good material. And it's important and mandatory to suture both peritoneal, visceral, and peritoneum. I see it's a trend these days. I put it in red. I wonder our expert to tell us that is it not important to suture the visceral and the peritoneal and the parietal peritoneum? Because there are literatures that are flying around in other journals of low impact factor, which says it's not important, and you suture like surgeon, general surgeon, mass closure. And I meet as a urogynecologist for complication of that. The woman, the uterus, the raw area of the uterus adhere to the abdominal muscles and form an adhesion there. Then that adhesion, it constricts the bladder. The bladder cannot expand because now it's entrapped in there. And the women present to us with either frequency of urination or agency to urinate because failure to, because they don't suture in the peritoneum, they say it's not necessary to put the bladder back up. It remains downwards, becoming next to the vagina, and increase the chance of cystocele and urinary frequency. I'll show you how it is. And our experts should tell us like this. In a non-pregnant woman, we have got anatomy like this. But once it's pregnant, the uterus is next to the abdomen. And when you cut in the lower segment, the uterus is still big. And there's a raw area in the lower segment of the uterus and a raw area inside the abdomen where the peritoneum, which would act as a barrier, is not there. It forms an adhesion. I see on the average, I haven't counted, I think every 6 months I must see 1 or 2. And it makes it makes if the bladder is down, of course, it will give you a cystocele, but it makes the adhesion that uterus adhere to the anterior abdominal wall and constricts the bladder expansion. The bladder can expand anywhere. Lack of space for urinary bladder expansion leads to frequency of micturition of small amount of urine. And because of that, the patient is feared to drink water because she keeps on going to the toilet and she gets dehydrated. This is what typical thing that I'm putting here to stress that all layers must be sutured layer by layer. This is what a patient presents to a urologist. They do a cystoscope, everything is fine, but they see the bladder is small but doesn't need bladder augmentation. And if you come to a gynecologist to do laparoscopy, you see that there's a band between the uterus and the anterior abdominal wall, and the bladder is distal that side. If the bladder is that side, then you have to release that bladder from that side. This is, I usually do it by laparoscopy. Only last week, I've seen another woman like this one. And that one, I don't think I'll be able to do it laparoscopically. I can only do it by laparotomy, where the uterus is adherent to the anterior abdominal wall. And that adhesions in this way on the right side, the adhesion on the left here, I cut it with a Caesar. The Caesar must also have a cautery on it because sometimes it can bleed, and successfully I managed to remove it. That is because of the shortcut that is done in doing a cesarean section, not suturing the peritoneums. And if we don't suture the peritoneum, as you dissect through the Caesar, the bladder, you'll see it very well when it comes. It will be a shine. It's very red. That's the bladder on the right. It's very rare to perforate the bladder. I've never perforated any bladder I've done more than 20 of them. That's why I'm a proponent that all peritoneum must be sutured. But the literature, people who are reading literature will tell us. Once you release the bladder there, then you've got a woman who has got a good bladder that can expand. And when you finish the Caesar, you can wash out, and you will see when I push the fluid inside the bladder here, the bladder expands so much that you really see, this is the fluid that I put inside the bladder. You see the bladder now is coming. Then she can retain about 450 to 500 mils like a normal female, while she used to retain 250 to 300 because the bladder was constricted inside here. This complication, people don't see, but as a completion, any laparoscopy, the woman will going to tell you, am I going to have a baby? I usually do chromopetubation and inject the dye to see whether the tubes are patent or not. If the tubes are patent, I'm fine. I always tell people, and I stress, there's no race in doing a cesarean section. You can't praise yourself that I've done it in 20 minutes. Take time and do normal things. Then otherwise you end up with the bladder which is trapped here, which is going to give the patient a complication. It will jump from urologist to anybody, and it's not very easy to come with a diagnosis. But nowadays, with my experience, I realize that if bladder is entrapped, we just release it, then it will come out. So in summary, do not rush. Take time to proper operation. There's no rush in operation. In conclusion, ladies and gentlemen, Caesar is a safe and reliable method of delivering a baby. It preserves the pelvic integrity, pelvic floor integrity and function, and prevents things like future pelvic organ prolapse and stress incontinence after menopause. Preserve sexual function by preventing vaginal laxity and vaginal gaping, secondary to dilatation or tear. And I think, I'm not a stranger to controversy. I've said so many things in life and booed in congresses, but after some time, those things that I've said have been done. I say it is going to be the preferred feature method of delivery, seeing that the family size is reduced and the intimate genital function is taking preferences. So women love themselves. If we love women, we love themselves. They can't spend money coming to us to do vaginal tightening and nothing to please the men. The woman mustn't be ashamed of herself because you must live with comfort and confidence. When I say a woman is confident, it's when a woman, the pelvis is confident. Ladies and gentlemen, thank you. This is the little that I wanted to say, with little controversies and other things, some of them deliberate. But since you have got experts, and thank you for your listening to me, the majority of you managed to stay here. Thank you. Let's go for discussion. Our discussion will be this way. We're not going to allow questions for the masses now. And if we're going to ask questions, you won't ask me. Now I'm not going to talk. I've talked enough. The Professor Maswime and Professor Monukwan will be talking. But usually, courtesy says ladies first. Let's start with Professor Maswime. Professor Maswime, the stage is yours.
All right. Thank you so much for a great talk. I think you've covered so many aspects. I feel like this should have been split over 2 or 3 nights because, there were so many issues.
Just the microphone next to the mouse, Prof.
Is
microphone
it
next to
okay?
the mouse. Did you hear me, Prof?
Is it better?
Talk, let's hear. Speak, let's hear you.
Yeah, you hear me?
Yeah, I can hear you.
Can you hear me?
Yes.
Yes, we can hear you, Prof.
Doctor, we can hear.
Saying thank you for such a
It's disappearing, eh?
comprehensive talk. I feel like you could have split this into 2 or 3 nights because you've covered so many aspects initially to some of the...
We can hear you clear
on our side. We can hear you well.
Right. So maybe it's you, Dr. Mahapa.
Okay, fine. Go on. I can hear you.
All right. All right. Thank you very much. Yes, I was saying that so many aspects were covered, which were extremely important, from the social aspects that you spoke about into the clinical aspects, into the very technical aspects in theater when you're doing this and the incisions and all of that. But the things that I thought stood out for me that I wanted to touch on, and I think firstly, I think issues around consent, or maybe let me start by saying, you know, there are disparities, right? You've given the talk very much from, you know, women who are able to access cesarean sections when they need them, and because they can access them, they have choice, freedom of choice. They can ask their doctors, I want to have a cesarean section, even when they don't need it. But the majority of women in this country do not have that choice. And the majority of women are women that will need to have a cesarean section for life-threatening purposes. And in a health system where even if they want to have the cesarean section, they will not be able to request it as they want it. So I think it's just important to mention some of those disparities, because you've got a small proportion of the country that overuses cesarean sections even when they don't need them. And then you've got a much larger part of the country. And I think many of the people perhaps who've joined tonight may come from different backgrounds and have different questions and concerns around access to cesarean sections. We do find as well the issues of consent, even though women are very independent now and make their own choices. But you do find women who will refuse to have a Caesar until they've gotten permission from their husbands and the spouse. At that moment, the child is in danger. You need to do that cesarean section quickly, but women are afraid of giving consent and giving permission because they come from a background where they cannot make that choice on their own. The reality of complications, I think we didn't touch very much on the complications, but the reality that women can bleed during cesarean section, have anesthetic complications, women get sepsis and infections after cesarean sections. And when we talk about cesarean section safety, it's really to say that even though majority, more than 90% of women who will have Caesars may be fine and not have major complications, but there is that percentage of women who may have complications that may lead to death. And those are the realities that we face in this country and in many other African countries. So the choice of whether to have a cesarean section is not a light one. And I completely understand some of the issues around, you know, the keeping intact your vaginal muscles and all of that women may choose because of that. But there are also some serious dangers and complications, and women who have lost their lives because of the lack of safety with regards to cesarean sections. You touched on the issue of convenience, and I like that you touched on that, because it's many choose to go the route of cesarean section out of fear of what might happen if they don't have a cesarean section, or the worst that could happen if they have if they deliver normally. But also that the issue of convenience is both from the doctor's side and the patient's side. And doctors find themselves also stuck now with patients saying, I want a cesarean section. If you're not going to give it to me, I'll go to somebody else who'll be willing to do the cesarean section. So we're living through very tricky and difficult times where it is being perpetuated that it's doctors that are pushing to do unnecessary cesarean sections, but we also have a very enlightened community that is insisting on cesarean sections sometimes when they don't need it. You also spoke about issues of quality of life, and we don't always take these as serious. And I appreciate your experience with as a urogynecologist, because not all of us see the women when they come back with all of, you know, the vaginal laxity and all of that you mentioned. But these are things that women suffer in silence, and we haven't created safe spaces where women can talk about these things, where women can tell their mothers, their sisters, their friends about some of these things. And so we have to think about what safe spaces are we creating for conversations around what was your childbirth experience, what did you choose, why did you choose it? And we need to think about those as well. And then yeah, I mean, we spoke around a lot of clinical things, and I'll leave some of those to Prof. Monokwane to touch on. But the question, you know, it's difficult to say that Caesarean section is the best option, and I would be lying if we say to women that, you know, we recommend all women have Caesarean section. We don't have the facilities to do that. Women wait for hours and hours in some of our public sectors waiting for a Caesar. Women have delivered through normal vaginal deliveries for centuries, safely so. But as gynecologists, we see the complicated women, we see the worst cases, and sometimes our opinions are a bit skewed because we sit on the other end where we see the worst outcomes. So I think I wouldn't perpetuate the notion that, you know, Caesarean section at all costs. We've got, let's use those muscles that were put there. But at the same time, I fully respect that many women have complications that affect their quality of life, that affect their marriages, that affect their sexual pleasure. And it's important that we pay attention to that women are counseled adequately beforehand, that women are aware, and that let's prevent them and ensure that, you know, we make timely decisions. If a woman needs a Caesar, let's not delay it, but also let's not rush into the Caesar before the woman actually needs to have the Caesarean section. So let me pause on that note and allow Prof. Monokwane to add a few more points. Thank you.
Thank you very much. Very mature and educated lacune that I have filled up where the gaps where I had and straightened where me, I'm in private. You know, in private, I'm practicing commercial obstetrics. These are academic. They practice evidence-based medicine. As he said, if a patient I don't do a Caesar, I'll go to the next person. So commercial obstetrics and academic obstetrics, they differ. Thanks you very much, Prof. Let's hear Prof. Monokwane. Prof. Monokwane is a friend of this area. He was once the head of the Department of Obstet Gyne in Medusa for a long time. Now she tells me that he's retired. I say, you can never retire. You still do teaching in Medusa as a retiree, as an emeritus professor. Professor Monokwane, the stage is yours.
Thank you, Dr. Mahapa. Thanks, Prof. Maswin. I think you call us experts. Experts, by definition, is somebody who does whatever in mechanics or in building over and over and shows results of expertise above any other. But in short, I think we can be called experienced obstetricians. There may be in the audience more experts than us. But coming to the points, and thank you for a good topic, very important. Remember, there's been a lot of criticism about Caesarean section rates in throughout the world, but in South Africa, around 32% in the public sector. When I left, at least we're putting it around there. And in the private sector at 75%. So that's much, huge. And when you look, indications are very important. Now, you put the first controversy or aspect to discuss is maternal request. Now, maternal request, there are two aspects to it. it will be patients who, majority of our previous Caesar times 1 decline VBAC, and therefore it's a maternal request, but there is a reason. So we don't concentrate much on it. And we say maternal request is often on women who have never had Caesar before, and they come and say, because of, I like what the British are calling tocophobia, they have a fear for pain during labor. Others are from sheer experience. They've had normal vaginal delivery that ended tragically with death of the baby or cerebral palsy, which is our biggest challenge currently, medical legally. And therefore, would say I opt for Caesarean section. Now, the SASOC has also put a very good better ops advice, which is based on the American College of Obstetricians and Gynecology. The Americans feel, no, you should not offer every woman routinely, per request, routine Caesarean section. It must be per indication. 2, if you don't have any medical or obstetric indication, counsel the patient appropriately for vaginal delivery to hear what are the concerns and fears. If it's pain, offer epidural, offer another person to be with the patient so that you decrease anxiety. In the UK, they had a very nice analysis, despite any, as I nearly said NHI, but the practice in the UK is saying Caesarean section per request. Now, many trusts are areas or hospitals which will be offering the services. They found that only, despite the rule that says, that addresses that, counsel the patient and offer, if possible, many of them don't. They were chasing patients away to other centers and say, it's like TOP. No, here we don't do Caesar per request. So only, which was 27%, very interesting, almost a third, were the only ones who say, after counseling, if the patient still insists, they'll go ahead. But remember, you must tell the patient morbidity and mortality by Caesarean section versus normal vaginal delivery, there's no doubt. Caesar gives more risk. However, we say Caesarean section have become safer. And as Prof. Maswina said, we haven't eliminated the danger factor or the complication factor. So in the public sector, largely we don't have such patients coming in and say, I want a Caesar I'm fearful of. Is because more of the time we push in for what are the indications for Caesarean section. And perhaps I like this talk for one thing, to open up to say, I'm one of those, like you mentioned, teenagers, that 14-year-olds and so on. Yes, allow them labor, but have a short threshold for giving them Caesarean section. I'll tell you, I went to defend Bara when Prof. Maswimi was still there. They had about 35 or 48 going to total 40-something cases. And these were cerebral palsy. When you look at the files, some of the files, of course, were missing. You realize that Caesarean section should have been done earlier. And there has been delay and delay. And hence, the use of the pathogram is so important to guide us. When should we intervene in a patient who's in labor? But as per maternal request, I agree that in the public sector, it becomes difficult to offer routinely, given the fact that we are faced with many obstetric challenges, previous Caesars, big babies, breech presentation, multiple pregnancies. Those are under elective. And emergencies, we have cesarean, fetal distress, failure to progress, previous Caesars or failed VBAC, and hypertensive complications as you have put them. So I agree with you, Dr. Mahapa, that maternal request for cesarean section, we should look at that topic openly, even in the public sector. Two, let's allow partners in. When I came to George Mukar, then Harankua, I drew a policy that allowed, the matrons were fighting with me. Prof, this is not possible. We cannot be allowing partners in. I said, black men usually run away when the woman is in labor. What's your problem? But there are men, one or two, who wants to be there, especially the modern young fellows. I like them. They accompany their partners for antenatal care. Two, they are happy to be there in theater. Why not? This is the father. So we had hassles, but I drew up a protocol that allowed partners to come in. The second controversy you put was, should we be allowing shaving or not? Now, Better Practice Initiative did show that, or discouraged routine shaving. Some patients actually, I worked in Natal, King Edward, but we rotated both in Addington and RK Kans. Some of those in the Indian community, they will shave even before coming to hospital. Now that is discouraged because colonization, skin cutting, then you have bacteria coming in. What is recommended is to use, and unfortunately, not many hospitals have clips where we just like men, as we trim our head cut with a trimmer. That is actually what is recommended, but half the time is not there. Pre-op, we just take a blade and just shave a little bit where the hairline, where you are going to do, especially for fan and steel incision. So I agree with you that literature is against that, but practical sometimes, because we must avoid doing an incision over the hair where there is hair. It can never be healthy. Too, that healing becomes disturbed, infection rates may be increased. So for cosmesis and for health reason, trim or shave just before the Caesar, and that's what we do if we were unable to trim with a machine, because it's not always available. Controversy or important point that you brought out also, number 3, was to suture the peritoneum or not. Now this is, and I agree with you, that we must individualize and not take it. The visceral peritoneum, by and large, we don't suture. We say leave it. But the parietal peritoneum, now generally the literature says both visceral and parietal peritoneum. There's a Cochrane data to that. It only shows the short-term benefits, but long-term, it admits they haven't done long. And you're right, we've seen patients with adhesions. I've seen patients who come in, the parietal peritoneum having been sutured, the bowel herniated or entered into that space. So I tend to say individualize. When you look, is there a possibility that you should suture? And the parietal peritoneum, though it said that is the one that will yield adhesions, because that's the rationale behind or against suturing the peritoneum, it's better to suture in some of, especially obese patients, or where you show the muscles are so lax that bowel, the visceral may herniate. Is better to suture, because we've seen 1 or 2, some patients that come in with these complications, and you'll find the surgeon scolding us, you should have sutured this. But let me go on. You mentioned Professor Kurtzem, who I was lucky to witness when he did subtotal hysterectomy in King Edward laparoscopically. And as you said, he's one of the German pioneers of modern laparoscopic hysterectomies. Now, Professor Kurtzem would always say, don't cause a problem. Why he even went for subtotal to leave the cervix, but he left it. The cervix offers you the support, because the uterosacral ligaments attaches to that and hold it uterus so that it doesn't prolapse, and invariably the vagina. But he used to emphasize the coital ecstasy that comes from, you have the clitoris, the G-spot, he would add that the cervix is part of women sexual satisfactory point. So when it comes to suturing the peritoneum, he used to say, don't suture it. But when we went for laparoscopy, we would see that, and with Dr. Quinlan, who I used to assist at St. Augustine's, who introduced LAVH in South Africa, we used to, together with, you worked, Dr. Mahapa, with the chap at, in Johannesburg, I forgot his name now. When you go in laparoscopically, in those that you haven't sutured, especially visceral, we would find that more often nature has healed the visceral peritoneum very well. Parietal peritoneum, Quinlan used to argue with me that it also heals. But as I say, the literature says don't do that. But long term, they admit that there are patients who have come back with adhesions, the uterus, the bowel, etc. Then there was somebody who asked you, what is the definition of delayed cord clamping? We often say 30 seconds to 60. But indeed, you can actually, there's somewhere where it's written to 3 to 5 minutes. It can be extended to that. The American college has got that where you can extend it to 3 minutes, delayed cord clamping, so that there are benefits to the fetus. I won't go much into it. The other controversy you didn't tackle tonight was exteriorize the uterus or not at Caesarean section. Prof. Marivate used to always like asking that question, is it better to exteriorize versus? Again, it goes with one's training. I was working in Bupelong, Mafikeng. They used to say, Sam, exteriorize the uterus all the time so that you can have access, do your TLs and so on. I went to train in Natal, King Edward Hospital. No, Prof. Marivat and others were against exteriorizing the uterus routinely. Suture it in there. And he used to say, if there's a bleeder that you have missed, if it's left inside, you will see that earlier. I think, Dr. Mahapa, you've done a good job. It was too extensive. I've missed out on certain things. One of them, you said, always suture the rectus muscles. I would say no, not routinely. However, there will be cases where it's obvious the muscles have separated so much that in that case, put in a suture. But there are these young girls where the rectus muscles are still strong and holding very nicely. Once you have sutured the sheath, you bring in the skin, it often doesn't give us too much problems. And I do the follow-up. I'm against routine maillard incision where people are cutting muscles. When you get the follow-ups, both at hysterectomy, at Caesar, it's rare. But if you've cut the muscles, these patients tend to heal with adhesions that are painful, scars that are painful, and presents in the gynae clinic often. And you look, you don't find much. But when you go and search what was done, you see that the muscles were cut. These patients, they come back with low abdominal pains, particularly over the scar. The rest of other factors that you've mentioned, thank you. I think they were clear. Should you use 2 or 1 layer to suture the uterus? I concur with you. We still do the 2-layer. Dr. Quinlan, who I used to work with, and mainly were white patients, when I assisted him, did 1 layer suturing. And when we do laparoscopy, he'll show me, Sam, look at that woman. 2 years ago, we did the Caesar, or 5 years. Look, the uterus has healed so well. So there's no difference in 1 versus 2. However, in the Black community, we find that the practice of 2 layers reassures us. Number 2, the healing part of it is important so that if this woman should want to deliver vaginally, we want to convince ourselves that we did a good job. Now, your last point that I want to mention, it was Professor Crichton, and thanks, I needed to greet Professor Mokokung, our father and pioneer who taught us in Natal and came over, taught you guys in Medunsa, one of the best great surgeons and an icon in the Black community as one of the pioneers in obstetrics. And we thank you, Prof. Mokokung, for allowing the Black child to become a doctor. Now, Prof. Mokokong, Prof. Crichton, they used to do studies about Zulu women. Always, even if they have had a Caesar, they believe in the Zulu culture, you are not a woman until you have delivered vaginally. So they used to see every 10 years, Professor Paul Bull and Professor Crichton, 1960, wrote about ruptured uterus. 1970, Prof. Mokokong, Marivate, and Pizzo, they wrote an article. 1980, so every 10 years, Philpott, Pizzo, I think, so all these guys were showing ruptured uterus, and this ruptured uterus was as a result of Zulu women trying VBACs at home because they were criticized. And Crichton came with a decision. We allow women 2 or 3, and 3 became the standard, Caesars. After that, closed, because they were seeing more maternal deaths. Remember, it was those times where families were having 6 to 8 children per family. Now, if you've done 3 Caesars and you're losing
right, it's image. Sam, I can't hear Sam. Can anybody hear me?
Yes, we can hear you. We lost him as well.
We can hear you. We can hear you, Doc.
Something gone wrong on his side, on his internet or something. Okay, thank you very much. You know what? It's good to have experts with evidence-based information. Most people in academic, they set the standard. And when I tackled this operation, I said, I'm going to come with my biased way of private practicing. That's why these professors, they filled on all lacunae. Then you can see that Caesarean section is not easy as such. Since the time is gone, I'll allow only 3 questions, and they won't be answered by me. They'll be answered by either Prof. Monokwane if she comes back, or Prof. Maswime is here. Ladies and gentlemen, raise your hands for 3 questions. I won't allow much. Time is gone. Can you hear me?
sorry for taking too long, but I had to do your controversies. Thanks,
Okay,
Dr. Mahapa.
because somewhere you got cut, Sam. I was saying I would allow these people to ask you and Prof. Maswime some few questions, and we hear what kind of questions I'm confronted with during this webinar. And please, ladies and gentlemen, ask questions related to Caesar. People come here and ask questions related to the other conditions that they have. That is with no relation to Caesarean section. Please have an opportunity to engage with the 2 professors. I'll start. The next question that's going to come will go to Prof. Maswime, irrespective of who asks it. Do you know how to raise your hand? Raise your hand. I'll show you. I'll see you. And you know how to raise the hand there. Okay. I'm a devil's advocate. I'll choose.
I think it's at night. People are hungry, so they might not be.
No, let's just thank them. Just give a
Dr. Mahapa.
Hands are up. Yeah, hands.
Our hands are up. Maybe you are unable to see them. My question is just simple. I want to know. Am I audible? I want to know the maternal request of a cesarean section. Is it allowed in the public sector?
Prof. Masime?
Thank you very much for the question. In general, one can really say it isn't allowed, or it isn't allowed as generously as you can't just say I would like to have a Caesar because I want to time the birthday issue. It doesn't work like that. But in the case of a woman, for example, who has had a previous Caesar ×1, who has delivered by Caesarean section once, that the conversation can happen and they can request to then deliver the next child by Caesarean section. I mean, yeah, and it's only under those circumstances where the conversation around whether a woman can choose between a Caesarean section or having a normal vaginal delivery comes up. Otherwise, under normal circumstances, there just isn't capacity to have that conversation or to make that kind of decision to create that level of liberty in the public sector. Thanks.
Thank you. The next question, because my computer is small, the grid can't see all the hands. I can only see a few people. If there's anybody, just unmute and introduce yourself and talk and ask. The next question.
Good evening. It's Muime, one of the rich from VETS. Thank you, Doc. Thank you, Prof. It was actually very interesting that today I had one of the Caesars that just complicated. Ideally, when you have a second prolonged stage, you tend to have all these methods that we have been taught about. And when I went in, it was a 28-year-old para 1 graph. Actually, it was a graph 0, graph 1 para 0. She had been in labor, I think, from 7 a.m. this morning, waiting for Caesar, if not mistaken, from yesterday, because the patogram was already crossed from 7 a.m. this morning. So I did anticipate that this will be a difficult Caesar. I examined my patient prior starting caput 3+, and I could feel that this is caput and the head was already impacted. So I then I thought I'm going to just go straight and do a midline incision, even though it's a preemie, because I had anticipated that this might not go as I have planned. I did a classic incision. I asked the midwife to push, but it was not so much of a struggle, but I was very, very surprised. We ended up with a tear to the cervix. Lucky I did not injure the arteries. I did not, I reflected the bladder well as I had expected, but it was a bad one. So I had been asking myself, were there something that I could have done? Could I have done reverse bridge? Could it have been better or what? I even read on it, trying to figure out that having anticipated all those things, what could I have done to not ended up with such a tear? And a consultant had to come out, but lucky the patient didn't bleed.
Any input, Prof. Munukwane? Do you have, it's not
Yeah,
a question
quick
per se,
one.
it's just a discussion.
Yeah, I must thank the doctor. I missed the name, but registrar at VETS.
Yes, Prof. I know you taught me.
Yeah,
he examined you.
Yes, I was in Medwindsor. I graduated 2016, so I know, Prof.
Oh, he was your head.
I wanted to, in the topics that I wanted to, was to say, a special entity is difficult Caesarean section. We didn't go much into it because as an entity, prolonged second stage is one of those, placenta accreta syndrome, one of those, and many others. Some would even put in fibroids, etc. But what she has mentioned is so important. Philpott, my teacher in Devon, who created the patogram, wrote a very beautiful textbook called Obstetrics in the Third World. Now, in it, he favored exactly what you've done. You've got this obstructed labor, the head is impacted deep in, go and stop meddling lower down because the lower segment has ballooned. You're likely to injure the uterine vessel or extend, tear lower segment cervix into the vagina. So you end up with major problems. Classical Caesar, pull the baby out nicely. You find that it lessened the problem. And indeed, it's unfortunate in this case, the fact that you had an extension into the cervix means it's iatrogenic, where you put that hand trying to dislodge the head. Whereas if you had somebody push from, the literature will talk about the what pillow and so on. Those, when you are in an emergency, you're sweating, you don't have time for that. And in South Africa, with poor resources, but classical Caesar, I concur with you. It's one of the best options. Pull that baby out, whether it's reverse breech or whatever, but you'll have avoided. The aim was that you avoid meddling in the lower segment so that, one, you don't experience complications, two, you avoid bleeding, because that's what kills a lot of patients. So thank you, doctor. The best is classical Caesar, pull the baby out.
And Prof, I think I wanted to just follow up that. Would you encourage that if it's hard impacted, rather do reverse? Because at this point, the sister did a wonderful job. We literally got the baby out. I was just even thinking that could it have been that the lower segment was probably edematous. I usually delivers those ones. You will have just nice tears, but this was my first time whereby I was really surprised that they had, that was the only thing, but the sister did an excellent job by pushing the baby out, but we still ended up with those problems. The patient has been fully dilated since yesterday, if I'm not mistaken, but the pathogram was already full by 7 o'clock this morning, and patient was booked yesterday at 4 in the afternoon.
Okay.
Yeah.
Thank you very much. I
Techniques
said,
for delivery is the push technique, the fetal pillow, and then the one that you say reverse. But reverse often refers to when you have done a lower segment Caesarean section. Now, in this case, you should choose your incision prior to delivery. So while the head is still being pushed, to say avoid the ballooning section of the lower segment. But so that we cut the discussion, I would say classical Caesar gives you the best outcome.
Okay, thank you.
okay, listen, I had said 3, but I'll use my own benevolence. I see here 3 hands, Timothy and Mulalo. The last hand will be that of Dr. Denga. Dr. Denga is one of the senior gynecologists here in Petersburg. I think when he qualified his fellowship, I was going for my primaries. Same year he qualified, I went for my primary, same in Medunsa. But we work here in the same hospital, in the same province, and we behave as if we were classmates, but he was my senior. Timothy, give us a question.
Okay, doctor. Thank you very much. My name is Timothy. I'm coming from a patient point of view and support to the partner. I don't have experience with, I don't have academic experience, and I'm not practicing. I'm just a patient. And thank you very much for the session. We learned a lot. But my question was, it's more of after Caesar. The rest we heard today about the process and what's required. You'll guide us properly if it's a myth or it's a reality. I'm just a bit skeptical about the pains that comes after. Sometimes we may hear people say when it's cold, after the Caesar, there are pains and all that. If there are pains, are there any way to deal with those pains? And the other question is on the number of Caesar section you can perform in one's life. For example, if like now or going for the second pregnancy, then we go for Caesar section. Is it going to be the last? We'll never have other children in life, or how many times, or how future is going to look like? So that will be all from my question. And a bit of more history. You know, there's a lot of myths which are going around, or historical. If someone maybe had a bad experience during that process, especially in public sector. So it's care one to consider it. Maybe any there to prepare one for the in case there are unfortunate events. Thank you very much.
Free for all, profs. Any prof can take it.
All right, let me go. I'll answer some of the aspects. I think you raised two important things that, you know, in the discussion didn't really go into firstly, how to look after yourself and care for yourself after you've had the Caesar, care for your wound, your scars, all of that, the pain management afterwards, and the reality about, you know, especially, you know, in African circles, we talk about that pain that's related to the cold and all of that. And also other things like if women have sterilized, that, you know, they will have pain that comes and goes. Now, our textbooks will typically tell you that those pain, that it's a myth. But when women are going through that, they are really going through that. And they are not lying to us about it. But I do think, I mean, I won't go into details, but I think, first of all, it's important. What we want to prevent is infections. I think more than anything, within the first few days, we do want to prevent women from getting infections, because if you're not looking after your Caesar and your scar properly, you can get an infection, which could end up, you could actually lose your life because it can deteriorate quite rapidly. So it's important that women are also taught and educated on how to look after the wound. In the hospital, you're all in the same ward, same bed, but when you leave the hospital, you go to different homes. Some of you are living in crowded spaces. You are not, you know, you have different levels of being able to have that hygiene that is required. But I think it's important that education is provided, and then on the safety of medication and leaving the hospital with pain medication, because some women really struggle and there's a pain. So the pain tolerance is very different for women. As to the number of cesarean sections, what is important to note, we cannot prescribe. What we know is that for every cesarean section that you have, the chances of having complications in your next cesarean section get higher and higher. And for some women, it will be in their second, in their third, in their fourth pregnancy. So if we say to you, have 5 cesarean sections because other women have done well, and you happen to be the one that ruptures in your third pregnancy, or you have your placenta previa, accreta, etc., we will not have done justice to you. Every womb heals differently, and it's important that, you know, what we inform you of is what are the likely complications and the chances. And then the psychological preparation is important, and just to understand the difference between an emergency cesarean section and a planned cesarean section or an elective cesarean section, where there's a date that is set, you'll do it at this time. So women have got the time to go for counseling and to prepare themselves and their minds for it, and to ask all sorts of questions and read up. But the women who have an emergency cesarean section are the ones who often struggle, because they would have planned that they are not going to have a cesarean section, and now suddenly when they are told that they have to have a cesarean section, some of them are afraid. Some of them haven't read up enough about it, don't understand. There are all the assumptions that they are going to die if they have a cesarean section. So it's important that throughout your pregnancy, you are reading, trying to understand, asking questions. In the event that you have a cesarean section, that you are also prepared for it mentally, because then people start regretting that they had a C-section when they had not prepared for it, or people are criticized that they are not truly women because, you know, they didn't push and all of that. And all of those things are not necessarily true. But I agree that those aspects, the real human aspects around the Caesar, need to be discussed, and women need to, and men need to be in tune with them as well. Thanks.
Thank you. Mulalo, Rachivuma.
Thank you for the platform, Nandi One. Dr. Rashivumo from Rustenburg, JST, also part of SMU Ops Registrarship. So my question goes to the packing of the abdomen with the swabs, just to prevent the spillage. I haven't seen it being routinely done. It was actually my first time hearing about it today. So I wanted to ask, so in this scenario, ideally we would be packing with the wet swabs during the cesarean section. And my question is, should we routinely do washout to aid in making sure that we take out all those cloths, whatever might have spilled that could not be contained with those swabs? Should we routinely do the washout? The second question goes to the patients with high body mass index. What is the preferred skin incision, the midline or the transverse? Yeah, and then the third question, in terms of those patients that we find with massive adhesions, there are some abdomens that they are not, where the anatomy is completely distorted. So it's more like you are just doing a damage control in a way, just to safely get to that uterus and then repair whatever you can repair. It doesn't really follow the techniques that have been laid out as you were giving us the step-by-step way on how to do a cesarean section. So in that case, when we have those kind of cases, should we ideally have the consultant come in, because it usually doesn't follow the anatomy? Thank you.
Thank you. I know, professors, what impressed me is that we've got registrars here, and they're asking you questions that you are likely to ask them in the exam. Okay, I think Sam, do you want
That's
to take
correct.
it?
Yeah, just a quick one. I think she's raised a thank you, doctor, for raising this important point. Dr. Mahapa and I, we trained in the olden days where it's routine to put in swabs to reduce this risk of blood into the peritoneal cavity. Secondly, you have meconium stain lacquer. Sometimes you do scissors in patients who have choriomnitis where the lacquer is already infected. So if you don't routinely pack, you're likely to expose these poor women to sepsis and so on. And now that you've said it, I think I've retired, but Tuesdays, sometimes they put me on call. And last week, I think I saw a lady who was 24-year-old. She went in for Caesar for fetal distress, meconium stain lacquer. But she ended up with overt sepsis that day 11. A hysterectomy has been done, and it's written that she had so much sepsis in the period, HIV negative, no other risk factor pre-op. So you ask yourself a question, why? What happened? They wrote the 3 liters of pus in the peritoneal cavity. I'm happy with what you said, and that was my comment, that this patient must have had a spillover during cesarean section. Now this has resulted in severe sepsis. Sadly, the patient ended up with a hysterectomy at a very young age, 24. So the point is that never omit some of the basic teachings that we give. Heck, you lose nothing. The important thing is, as Dr. Mahapa emphasized, mark with an artery so that you don't lose that swab into the abdomen, but it helps to peg. If you didn't, it will be safer to do what you have just asked as a second question. Should you be doing routine, therefore, washouts, normal with the normal saline? And I would concur with you that that will be the best way if you didn't. The point here where registrars don't put in swabs thinking that no, that it doesn't bleed too much, may create a problem. And some of the adhesions that we see is the spillover of material from the uterus that has gone in. In the olden days, Professor Crichton, because of overt sepsis that was going on, he introduced what was called extraperitoneal Caesarean section. King Edward, we used to do it in Devon, where you do your fan and steel instead of, and then you suture the visceral peritoneum to the parietal peritoneum. In other words, both of them, you aim to cut them transversely so that you can suture. A very difficult technique, may I say, because you create a window, but the aim of the window was that you remove possible sepsis into the peritoneal cavity and exteriorize. That is why it's called extraperitoneal Caesarean section. And in the old literature, it's still quoted. So the aim is to eliminate possible, because you know, as a woman, when you ovulate, middle smidge pain that the Germans call, it's actually fluid and blood from the rupture of the follicle, and it irritates. Some women literally feel that pain. Ectopic pregnancy, the severe pain is blood in the peritoneal cavity. So to minimize the pain and recovery post-op, to leave the abdomen as clean as possible as you found it. So I concur. Peg, if you didn't peg, please wash out. Thank you.
Thank you very much. Wodenga.
Thank you very much.
Wodenga.
Yeah, Mahapa.
Mahapa. What about your hand is no more down?
Can you hear me?
Yeah, they can hear you, Denga.
All
Yes, we
right,
can hear
all
you.
right. I really enjoyed the topic, and I agree with Prof. Maswime that it could have been just put into 3 parts, because it's so extensive and it's so detailed that you feel like you've gone back to the class, and truly we were back to the class. Now, my issue is about these Caesarean sections where we're closing the skin, and there's so much talk nowadays of these negative pressure wound dressings. I just want one of the professors to make a comment about that. The other one, of course, in our local, communities, the idea of most ladies is to achieve a normal vaginal birth. It would be very difficult to shift that approach to have a cesarean section. Majority of ladies, if we look at them and analyze them, they just come to the practice and say, I had come here, I want a natural birth. Majority of them. Now, when we look into the general population, I think we have a few patients who end up at the urogynecologist door. And I think, even if that is the situation, to promote cesarean section wouldn't be the best idea, especially when you're looking at the complications related with the surgery itself, and the morbidity related with bowel function and all these issues of urinary problems, which ideally are not part of the natural deliveries. And my comment there is just that we have very few patients after natural birth who would end up at the door of urogynecologists. Now, my other thing is the question which I want to raise is about the omentum. When you finished with the Caesar, you always have a choice of whether to push the omentum back so that it falls behind the uterus, or should we allow it to come over the wound? What are the options there? Because it would seem like these relative bowel issues could just be related with the omentum, whether it's lying behind the uterus or it's lying on top of the uterus? Those are my questions. I'm sure my professors, the esteemed, they will look at it from their angles. Thank you very much.
Thank you, Denga. Denga is a senior consultant. If Denga had stayed in the academic, we would be calling him Professor Denga. That's why he asked a question which is quite academic. He's not asking me. It's an opinion. He just want it's not a question. It's an opinion. These are things that called controversies. One believe in this school of thought, one believe in this school of thoughts. Free for all. Prof. Masina or Prof. Monokwane. Anyone take Denga?
Thank you very much, Dr. Denga. Very good to see you. I'll just touch on the one question about the urogynecologists, and I must agree, maybe we must say it categorically. In a province with 1 or 2 urogynecologists, of course, you will see all the patients with all the vaginal issues, all the vaginal problems. Meanwhile, the rest of us are delivering the babies with no problems at all. So I think it is important that we look at the ratio of these and the numbers, that to you, this is everything, because it's so many. It's the same as if we had invited midwives into this conversation. They will talk about the number of normal vaginal deliveries that they are having, where there are absolutely no complications. But as gynaes, we are called when there are problems. We treat the difficult women, the difficult Caesars. Our jobs are to do the Caesarean section. So naturally, we are ready to do a Caesarean section, whether or not it's necessary. And again, I'm just saying we must caution and remember that we are only seeing one fraction of the population. And when we want to make decisions that can influence practice and policy, we have to look at the big picture. So Caesarean section is a safe and necessary procedure, but there is a risk of it being abused and done for the wrong purposes, and we must be cautious around that. Thanks.
Yeah, just to support you, Prof. Maswime, Dr. Denga, thank you for the question. I went to this conference, I think it was in Johannesburg. It was funny. I was the only person who was advocating for normal vaginal delivery. There were so many in the audience who were crushing, no, women by nature actually should be going for cesarean. I said, it's for cesarean section deliveries. And I said, guys, it's impossible. Just take the numbers, and especially us in the public sector. But even in the private sector, you can't be delivering. Caesarean section should be per indication. Is it necessary? And what is the indication? So I would concur with you that as Prof. Marivate, I'm sure you might have come across him, used to say, do not interfere. You must just intervene. So at the end of the day, we aim for normal vaginal delivery to have a good outcome of a healthy mother, healthy baby. But once the pathogram shows us that things are not going well, we opt for cesarean section as an intervention. Unfortunately, it has become more of a, like in the private sector, the figure quoted, I don't know how far true that is now, at 75%. In the public sector, we have 28% to 30% cesarean section rate, at most 32, which means at least a third of women will need Caesar. 70% or more will deliver vaginally, and that's a good thing, because at the end of the day, we then have very, very low complications. Now, the issue of genital prolapse is related also to, remember in the olden days, women went to fetch water in the river, they were squatting, fetching wood. There was a lot of pelvic floor muscle exercise by our routine chores at home. These have all come off. Vaginal delivery, if you read genital prolapse, the first risk factor is normal vaginal delivery. Now, with Dr. Mnisi, he's here in Medforum, we were the unit was doing a lot of genital prolapse operations. And as I admitted, lots of these patients would go through the history. You'll be shocked. It's even para 1, para 2. It's not very paras women. And the sad part of it is that we cannot get hold of the files to see. But when you ask the weight of the baby, was the weight big? Was the labor prolonged? And you tend to get, they say, no, it's just an average sized baby. Were instruments used to pull out the baby, because those you think they're the ones that will cause genital prolapse. But I agree with Dr. Mahapa, we're seeing a high, at gynae clinic, every week, there's 1 or 2 new patients with genital prolapse, particularly in women 60 and above. So it shows something that is tend. Whereas when you and I were training Dr. Denga, we hardly saw. Prof. Mokokong will tell you he's never seen a woman, black woman with prolapse. But of late, we're seeing a lot of this. And they're related to, or the risk factor that we see has had vaginal delivery. So in some ways, Dr. Mahapa's point and concerns are very important. But I think it's labors that were either prolonged or too big baby. That's why we say no macrosomic baby must be delivered vaginally. Go for Caesar, so that we preserve the genital tract integrity and minimize risk of prolapse and urinary incontinence. The one of suction, we often use a suction drainage for patients who show pus coming out or sepsis, or where there is excessive blood bleeding, but having sure that you have secured hemostasis, or if the wounds are not coming up, the edges are not coming up right, but it's not a routine practice in the public sector. The surgeons, I know, they use it quite often. Of late, they've promoted it quite a lot, and I think it has got its merit, especially if the adipose tissue was very, very big. So in obese, somebody asked about delivery of patients with very obese. Should you go for Fan and Steel midline? Fan and Steel will always be the better, even in those obese, where you must put them on anti-Trendelenburg, wrap that, have the abdomen apron pulled up, cut, and then you take the tissue clips so that you get good exposure. You have 2 assistants, not 1, so that you have adequate exposure. But midline incision, invariably, Professor Taule Mokoena, the current health ombudsman, will tell you of how many hernia repairs that they were doing as surgeons in Devon as a result of obesity from midline incisions. So personally, I would also say go for Fan and Steel incision, deep as it may be, but slowly and surely you'll save the patient from hernia formation and other complications. Thank you.
Thank you, ladies and gentlemen. I've set this Zoom to cut me off at 22:30, and we're left with 10 minutes. I will just take this opportunity at personal level to thank all those who attended, with special gratitude to Professor Monokwani, who I'm so acquainted to. And again, Salmi Masime, thank you very much for agreeing to come here. And Sunday, I'll go to the church and tell your father that I was with you. Salome's father is our bishop at the church. So we are related spiritually. So thank you. Even in future, when I've got a topic that I think I'll give a biased view, please agree to come to me. To all those who are here, please, can you just unmute and cheer our guests, please?
Yeah, before they do that, Dr. Mahapa, the premier, Dr. Poppy Rama, Dr. Poppy, let me not waste time. Ask me, Prof, can't you come to rural areas, small hospitals, teach young doctors? We're having a lot of bleeding at or following Caesarean section. resulting Dr. Mhlari, who works at Polokwane Hospital as well, a gynecologist, who did intensive training, also is worried about the high number of young, even primary gravidas who go for Caesar, bleeding torrentially, some are dying. So I think the emphasis will be to teach safe approach to Caesarean section. So that I think as seniors, let's avail ourselves to youngsters out there so that we can minimize the deaths that are occurring. Thank you.
Thank you.
And congratulations, Dr. Mahapa, for a good topic that attracted so many people. Earlier on, I saw 300 and something, and I say, wow, that's excellent. Also, I need to thank Prof. Maswime. We met recently at the PhD Awards ceremony in Johannesburg. Prof, keep up the good work, but let's go and pass the pearls of wisdom, the skills that they can never get from textbooks, but by doing. Reverse breach extraction, the pathwarden method, which the Indians also promote as a modified reverse for patients with obstructed labor, are very important to teach to our youngsters. Dr. Mahapa, well done. Good night. Thank you.
Now it's time for you, attendants, all of you, to cheer our guests.
Thank you, thank you,
Thank you very much.
Thank you.
Come
Thank you
on.
so much for the lovely topic.
Thank
I learned
you.
a lot.
Good one.
I know you can make more noise more than that. Come.
Yeah.
Mahapa, we learned a lot tonight.
Thank you very much.
Thank you.
Yeah,
Okay,
but
I'll end this
going forward,
webinar
let's
now.
avoid politics in such topics.
Thank you.
Thank you. Let's not involve premiers and what going forward, because those ones will ruin our things. Let's continue teaching each other.
Lives are being lost.